start? Deal. Hi there, folks. I guess I won't start the presentation right on the nose. I'll say hi, and we'll take our time here. Hi there, folks. Welcome to our session this afternoon. Thank you for foregoing a after-lunch nap, at least for now. I appreciate it. My name is Vib. I'll introduce myself here in a second. But since we all just had lunch, I'd like to entice you all with a quick stretch and deep breath if you all are so inclined. We don't have to get up and as you are able, but just to reach up with your arm, reach up with your other arm, shake out your hands, and deep exhale out. Awesome. Thank you, thank you. We'll still be letting folks in. My name is Vib. I'm from Callan Lord in New York City. I'm going to be talking about gender-affirming surgery and our supportive services that we support patients with. If I can just get a quick raise of hands real quick, how many folks have seen patients that are coordinating gender-affirming surgery? How many folks get questions about gender-affirming surgery from patients? Word. Deal. Way more in the second one. Cool. Sweet. So we're going to be talking about some of that today. I'm not going to be talking about the individual procedures themselves in depth because I can give an entire one-day symposium on the procedures themselves. But we're going to be talking about coordinating surgery and supporting patients as they're coordinating surgery. Sweet. I'm going to go ahead and get started. Once again, my name is Vib Gonzalez. I am a coordinator. I'm the coordinator of TG&B Perioperative Care and Services at Callan Lord, which is a community health center in New York City. We are a FQHC, and so we see patients from across New York City. We have a lot of, I'm going to stand back just a little bit. Let me know. I'm a teacher, so I can also project if you all want me to, rather than using the mic, but either way. Can you all hear me in the back okay? Okay, cool. So I'm the coordinator of TG&B Perioperative Care and Services at Callan Lord Community Health Center. We're based out of Manhattan. We have a clinic in Brooklyn, in the Bronx, and then we also do a lot of satellite work at like community centers, different places where folks already go and are already at. I've been training and facilitating training since 2015, and I am from southern New Mexico. So I'm not from the tri-state area. I'm from a little bit further than that. I always like to start my presentations with noting Marsha P. Johnson and Sylvia Rivera. Have you all ever heard of them before? Sweet. Can I get a raise of hands for people that have heard of them? Okay, sweet. So a lot of folks. So if you haven't, I really, really encourage you to look them up. All of the links on my presentation are live, so you can always connect to them and find out more about the information within. Marsha P. Johnson, Marsha Pay It No Mind Johnson, and Sylvia Rivera are two trans women that are famous within our LGBTQ civil justice rights movement here in the United States. They're famous for Stonewall, and it goes back and forth between which one of them threw the first shot glass at the Stonewall riots. But we know that they were both present, and they are both big, big figureheads for us. They started STAR, which was known as the Street Transvestite Action Revolutionaries, back in the day, and they started this group as a group of peer supports for folks to go to and create community and advocate for trans folks. Sylvia, there's a really famous clip of Sylvia talking at one of the Pride, what could be considered parades or protests, where there was a lot of gay folks up front. There was all the other letters except for the trans folks up front. Sylvia got up to speak, and they all booed her off stage. There was another iteration of a situation like that when Janicet Gutierrez approached President Obama about things that were happening with undocumented folks that were claiming asylum, that are trans, that were being forgotten in a lot of the same ways. And she too was booed and banned out of the White House in the very same way. So this legacy of this advocacy of making folks uncomfortable, of calling out these things and these injustices goes even further than Marcia and Sylvia, but I can say for sure that I wouldn't be here doing this work without these women. And so I always start my presentations and my slides with noting them and noting the work that they've done. And then, as I've mentioned, I'm from Callan Lord. So Michael Callan and Audrey Lord are our namesakes, and they are a huge part of our orientation to care and the kind of care that we provide. A little bit about the patients that we take care of at Callan Lord real quick so that y'all can get the big picture. I'm not going to dig in too deep, but we have about 18,000 patients that we see on a regular basis. We flirt around that number consistently. Male identified patients make up the majority of our patients, with 47% of them being identified that way. 52% of our patients identify as folks of color, and about 1 in 7 identify as Hispanic or Latinx. Of those patients, about 5,000 patients identify themselves as TGNB. And I always like to give the caveat, as we talked about in our earlier presentations, patients may not identify as trans on their documentation. So this number and these demographics are only for patients that have self-identified as being TGNB on their patient forms. Trans femme patients make up the majority of our trans patients at 41%, with 80% of our patients being people of color, and about 1 in 6 identifying as Hispanic or Latinx. And about 10% of our patients are living with HIV, which is right in line with the worldwide statistics of folks that are living with HIV and have gender dysphoria. This bar graph with lots and lots of bars is the number of patients that are seeking letters each year, year over year. And so you can see a couple of pretty big jumps here in this presentation. So you all will see here, 2015, the Affordable Care Act was passed, and so insurance started covering surgery. So you see the big jump that we have here going on there. And we've just been consistently growing. The only dip you see here is the year of the pandemic, and that was still one of our highest years that we've had even to date. Our program continues growing, and last year we had about 1,200 patients request letters for surgery last year. And again, this is tied to the amount of patients asking for letters. So patients that had external providers or that paid out of pocket or that just weren't asked for letters in order to have surgery weren't accounted for. We still helped facilitate their surgery. We still helped coordinate their surgery. They just didn't come up in these bar graphs. I'm going to cite the U.S. Trans Health Survey, which at this point y'all have in your back pocket this morning. But just to note some of the same information that folks talked about earlier today, in noting folks' experiences within the healthcare system and within the ways that they're treated in those different states. One of the things that I like to name is that this survey has been done in several iterations, and we're just affirming what we know to be true, and that trans folks are left out of a lot of discussions, a lot of decisions, and a lot of the programs and access that we need to a lot of spaces. Another thing that we learn is about the impact that is made and the demand for these services. To that end, at Callan Lord, this is another interesting bar graph that I like to show folks. The blue lines represent patients that came in for trans health coded visits at Callan Lord between 2012 to 2021. And then the red are HIV coded visits. So based on the main diagnostic code for the visits that patients came in for, made these up. And so you'll see the top starts very HIV heavy, but down here where we are, trans health has now eclipsed the demand of needs that are being facilitated at our clinic. And we see this replicated in a lot of clinics across the country and a lot of folks that we've talked to in terms of the shift in what folks are looking for. Feel free to ask questions as I go. Feel free to raise your hand. Feel free to tell me to go slower. Don't throw hard things at me, but you can throw soft things. That's cool. Terminology, so we've already done a lot of terminology, so I'm just gonna kind of skim through. So this is another note on the meaning of being trans. We already jumped into a lot of these things and just some notes about who's considered or who's named a trans man, trans woman, or who might identify themselves as just a transgender person. I also like to note, in terms of time and telling stories, we use the pronouns and the names and everything that's correct today, no matter the tense in time that we're talking about in the past, right? So folks that might have known me before I came out as Vib, they're still going to talk about me as Vib and use he, they pronouns, even though they're talking about Vib in 4th grade or Vib as a toddler. Does that make sense? A couple of things that I like to note. There's no medical requirement to identifying as trans. Not needed. The desire to have any medical interventions is not even required to be trans. It's just identifying as something different than what your sex was assigned at birth. That's it. So if a person says they're trans, they're trans. There might not be a direct opposite, and that might also be true for their surgery goals or their medical transition goals or any of their goals in their gender expression. And then I have some notes on reclaimed terms and reclaimed terminology. Sometimes patients might come in and might be using terms that as clinicians or as other folks, we might not be using or we shouldn't be using. There's one term that I only use in the context of trainings, and that is still used by a lot of patients themselves, and that's the word tranny. And that's one word that is a reclaimed term. And the thing about reclaimed terms is that not everyone in the community is going to agree about their use. Not everyone in the community is going to be using them. My general rule is if it's your teeth that are getting kicked in for saying by that word and by the power that that language wields, then it is your choice and your right to take that back and own that on your own. That is what reclaiming terminology is. Queer is another term, and so a lot of older folks don't like us to use the word queer because it's associated with a lot of hard times and a lot of hard things that they've gone through in their past. And so some of these terms are terms that are coming through. I also like to name the intersectional experiences of folks. The experiences of folks that are migrating from other areas of the world and that are coming here to seek asylum and find gender-affirming care have a very distinct intersectional experience that operates differently. But we also have a lot of things that bring us together, right? A lot of folks that are undocumented have to deal with a lot of things that as trans folks, when we haven't updated our documentation, we end up running into the same kind of barriers in a lot of different ways. And so, yeah, any questions about that? One of the resources that I like to name for folks as a resource to pass on to folks that might have questions about models of gender identity or referring to patients or family or folks that are like, I just don't get it, is the Gender Book. The Gender Book has a free PDF that is online, free to download. You can order the book as well, paperback or hardcover, and they'll also donate a copy when you order a copy printed out. But it's free for anyone to download on any smart device. It has several different kinds of visual guides to visualizing gender identity. It also has guides to using pronouns, to adapting spaces, lots of really rad resources. So I always like to recommend the Gender Book for folks. This is my favorite one. It's the world. Another note about non-binary and trans folks. So just naming that we exist. And I like to name also that non-binary or two-spirit isn't intended to just be the third default gender. Right? There's a whole lot more that we're opening our world to, and there's a whole lot more that's there to explore and to be validated and that has existed for a very long time. Where you see Two-Spirit here, there's a Two-Spirit provider, a video from a Two-Spirit provider that practices in what is known here as the Northern United States, but in lots of indigenous territory and land in that area, and talks about being Two-Spirit and being a Two-Spirit practitioner, and talks with their patients, and their patients talk to us about just the difference it makes to walk into an exam room and see someone that they know has a lived experience. And what that does for their care and their ability to talk about what they need in their care and what they're looking for. Same with folks that see the decals or that see the signs or that see the flags and the different things. Especially in today's climate, this can really do a lot for folks. So talking transition, I like to name 3 areas of transition that y'all might hear folks in terms of transition. Transition for some folks has no end. Transition for some folks has a very finite end with a very finite beginning of something different for them. It's different for everyone. But there are 3 elements that usually folks might need resources within. So that's social. So things like changing your pronouns, changing your names, changing the way that you're dressing, the bathrooms you use, things like that. Medical. So whether you want hormones, whether you don't want hormones, also just being trans in a medical space, right? What does it mean to have gender nonconforming gender expression and walk into a GYN office for a regular PAP, right? What does that look like if I'm growing out my facial hair and I'm waiting there in that waiting room? And so just even that element brings in that trans facet of existing within healthcare, right? And then legal. So like we were talking about earlier, you change your name on everything. You're calling your high school to change your diploma because you're gonna have to apply to a job later. You're changing your car insurance, you're changing everything. Your winnings on the lotto ticket. You gotta change everything all the way around. So that's another component of where it can come in. And this can also be kind of hard in terms of IDs, in terms of mailing addresses, in terms of having access to any of this documentation. For some folks, this can also be, now with the policies and things that we have in some states, an easy one form to fill that can be a really solid first step towards getting in somewhere, towards filling out a lease application or having an ID to turn in at the gym to use the shower, things like that that can be really accessible in that kind of way. All right, now I'm gonna dig into things that we haven't really touched today. So surgery terms. We're going to be talking about some terminology that is used in surgery. How many folks have heard about gender-affirming surgery in general? Okay, cool. So gender-affirming surgery, it used to be called the surgery. It's kind of this like illusion car wash thing that like trans people go into and then come out looking this way, right? Well, I'm sorry to burst a lot of bubbles, but that's not the way that it works. It's a bubble that we burst as trans folks too, not being able to just wake up. But there's a lot of things that we can do. There's a lot of stuff that we have access to. And what I like to talk to folks, it's a lot more of like a sushi menu of things that you can choose from. It's a lot more of like a build your own situation that you can build with surgery. And so gender-affirming surgery just talks about any surgical procedure that is performed in order to help the person affirm their gender identity with their physical characteristics. Now, insurance does have, and for insurance to cover these procedures, there's a pretty distinct definition of it having to aim at addressing either a primary or secondary sex characteristic that is different than that would be expected of the patient's gender identity. And so of those are the primary and secondary sex characteristics that we talked about earlier today that include hair growth, tissue development, and the contours of all of those things as well, right? Facial surgery. So surgery that is done on the face. This can include, and I'm just gonna go parts of the face, all of this is written here. Feel free to do what you want, whether you want to take notes or not. But hairline surgery, right? So for trans femme folks, they can have hairline surgery. We can have, and then the rest of this is for either gender. Forehead, brow bone, nose, cheeks, jaw, chin, and tracheal shave. And I have some illustrations in the next slide to also show you all. And all of these facial characteristics, it's the prominence, it's the contours, and the angles of those facial characteristics. In what we do at Cal and Lord, and part of our doula program also incorporates talking to patients about the things that they find euphoric or affirming about their body already. The things that for sure they don't want to change. And so when we're talking about surgery, and especially facial surgery, we also talk about preserving ethnic features, preserving the features about your face that you don't want to be changed, and going to surgeons that you know are experienced with working with faces that look a lot like yours and what you want to look like in the future. And so we talk to patients about advocating for themselves or naming those parts of the face that they do or that they don't want the surgeon to touch, and being sure and being diligent in the documentation that we provide on describing that in the patient's expectations and saying the patient doesn't want anything done to their nose. The patient feels dysphoria on their brow, about their brow bone, about the contours of their cheeks, about this, that, and that, right? Non-surgical facial procedures can also include fillers, can also include hair removal to the face, and can also include fat grafting to the face. And so for some folks, if they don't want to have the osteotomy procedures or procedures that address the bones in their face, we can add fat from other parts of their bodies to add some of that roundness, to add some of that softness, and to add some volume. For folks that are also concerned about their skin elasticity or what their skin might have done after several years of trying to get other kinds of treatment, we also can do some of those fillers and some of that fat grafting to help smooth that out for them and help address that for them. Hair removal, so electrolysis or laser hair removal. Insurance generally only covers electrolysis outright, and usually we can write for coverage of laser in prep for electrolysis or as a part of the hair removal treatment. WPATH just added that hair removal for facial and body hair for trans femme folks should be covered by insurance. There are some insurance plans that will cover it outright as a part of hair that wouldn't congenitally be grown by what would be considered a cis woman, right? And so that can include chest hair, that can include hair on your butt, that can include different areas of the body as well. And then some folks also need it for their face, right? There might be some folks that are getting ready to have facial surgery, usually shave on a regular basis or go through some kind of hair removal, and then aren't going to be able to for about a month and a half after facial surgery. And so we have to think about what that's going to do for their dysphoria as they're healing from facial surgery and what we can do to mitigate that, right? And so for some folks, it means, cool, we'll schedule a laser treatment right before you go into surgery, and we'll get that taken care of so that maybe you have some regrowth towards the end of your healing period, but then we can take care of it after that. Vocal therapy. So vocal therapy is available for trans masc and trans femme folks, everyone all around. It works not only on range and tone, but also on behavior, also on intonation, also on projection, right? There's so many things that go into speech that speech language therapy can really help us with and can address with folks. A lot of folks that go on testosterone and are going through vocal changes, they might be singers, they might be teachers, they might be people that project and use their voice a lot in a lot of different ways, or they might just care about their voice in that kind of way. There are tons of apps. There are folks that do virtual or phone sessions also with patients. I hesitate to say that there's a lot of YouTube videos because there is a lot of YouTube videos, but it's also usually what I tell patients is go to a YouTube video of someone that still has the letters behind the name, right? So still look for those licensed providers that are doing those informational videos, that are doing those exercises, and that are going through that process. Vocal therapy is also very, very important for folks that are having vocal surgery. For trans femme folks that are having vocal surgery works kind of like a string instrument. Y'all are familiar with string instruments, right? The more you tighten the string, the higher the pitch goes. And so with vocal surgery, what they're doing is they're tying the top part of the vocal cords together, and so there's less space in that area than after. So usually we recommend that patients have the vocal surgery last. They can start on vocal therapy as early as they want, but if we know that they're going to have other procedures where they might be intubated, like facial surgery, we recommend that they have vocal surgery last so that there's no chance that any tubes or anything that's going down their throat is going to make any complications for that procedure. That being said, vocal surgery does not affect people's range altogether. The vocal therapy does that. So the vocal therapy will open the patient's range, and then the vocal surgery makes it so that they don't have to strain to stay at the high end of that range. So it's kind of like putting a new string on your guitar, and that's vocal therapy, and then putting the clamp on your guitar is vocal surgery. Does that make sense? And so the vocal therapy helps them also control the airflow so that when they do start talking again, they don't blow out their vocal cords with the first 3 words that they say. So vocal therapy can often be very, very important for vocal surgery and is usually really, really important to the rehabilitation and return to speaking. It usually involves about 2 to 3 weeks of not talking after surgery and a liquid and soft foods diet for about just as long. Any questions so far? Cool. Then top surgery. So there's top surgery for trans femme folks and top surgery for trans masc folks. As we spoke a little bit in the hormone talk this morning, estrogen, if folks are choosing to go on feminizing hormones, it's recommended that they're on them for, most recommendations are 24 months, 2 years. Then the minimum is 6 months. We usually recommend at least 12 months so that folks can develop the amount of adipose tissue in their chest before we place the implants. Implants migrate very, very easily. Implants change very, very easily. Also, they're probably going to have to get them changed out in a few years. So even if they get them at the 6 months or before the 12 months altogether, not a big deal. They just might have more fatty tissue that develops in other areas that might leave them maybe asymmetrical, right, in different ways. And so part of what I talk about with patients in general when we're planning surgery is that no one is truly symmetrical. We'd all look very, very funny if we were totally, totally symmetrical from one side to the other. And also realizing those expectations of like, hey, you'll get more fatty tissue if you stay on your hormones and we're adherent to your hormones. And then when you're adherent to your hormones, then we can get to surgery and then we know that you're going to get the results that you want, right? Instead of giving you surgery now, you being on hormones off and on every once in a while, and then you having fatty tissue push your implant off to the side and you're not satisfied with the way that your nipple looks after surgery, right? If we can just get them to the point where that fatty tissue settles, and then if they're on and off, cool. But we need that fatty tissue to build up in the first place so that we know where those implants are going to sit right after surgery. And then chest masculinization. The only difference that usually happens with testosterone is that the elasticity of the skin and the volume of the tissue changes. So you'll see more like droopy chest tissue, more kind of sagging skin, depending on the volume that someone has and the ways that they've been binding. They might get more stretch marks up at the top of their pecs. Folks that have been binding very tightly and for very many hours will often push the tissue beyond and towards their back. And to the sides of their ribs. And so oftentimes surgeons will lipo extra that will contour the rest up towards their sides. There are some surgeons that used to be in the practice of charging extra for doing that. We call that a fat tax, and that is illegal. So I very much let patients know that that's not acceptable and that all of that contouring is included in the codes for having top surgery. That being said, there are also some folks that opt for reductions. And so non-binary folks or trans masc folks altogether just might want less tissue in general, but might want to leave some tissue. For some folks, they have to leave tissue if they want to preserve nipple sensation in order to protect the nerves in that area, and so they leave a little bit of tissue. For some folks, they feel affirmed by having some tissue and having some volume, but want to be in the range of being able to bind and be as flat as possible. And that's what's euphoric for them. And so they have a reduction. A lot of the surgical techniques are the same. It's just the amount of volume that they're sucking out. That's it. That's all that's different. Deal. Here are some illustrations that I have of a couple of the procedures that we talk our patients through. So on this one, this is the facial surgery, and so this would be considered the feminizing side, and this would be considered the masculinizing side. And so on the feminizing side, there's the forehead and the brow bone being the blue, the roundness of the eye, the softness that comes here. They aim for what's called a heart-shaped face. So they're aiming to reduce the volume of the forehead, make everything soft and round. The arches of the brows, they move from being more centered to being more outward, right? So they might go from a bit more like this to having a bit more like this, right? To have that arch here. Now y'all are gonna like go around looking at everybody's faces like, what's the difference between everything? And so that's just what's considered feminizing. I also like to name that this is gender-affirming surgery on the face, surgery on the body is based on white people and white bodies. It comes from a lot of that. Nose jobs and rhinoplasties come from during World War II when folks were coming over and didn't want folks to know that they were Jewish. They came and they got nose jobs so that no one would be able to tell, and they were able to function in society. And so naming that exists and that was the initial objective of these procedures also helps the patient know, word, I want to keep that, but I want to do this, right? And so naming those things about those things and letting patients know, like, yes, this is on these beauty standards, and also you have your standards. You have your gender euphoria. These are just the options on the menu that you have to choose from. So you'll see the nose being significantly smaller, versus being a little what's considered more boxy. You'll see more contours, and these shapes are more for the bones and the fixtures that the bones are meant to have. A resource that I really like to use is Hillary Wilson, H. Wilson Illustration. She's an illustrationist from Johns Hopkins who has really, really great illustrations of procedures. I use her illustrations for the genital surgeries that I'll talk about here in a second, but has really, really awesome illustrations of folks with different ethnic backgrounds as well. And then this is just the difference between the placement of an implant for someone that's having breast augmentation surgery. So they can either go over the muscle and over the fatty tissue or underneath and have that as an option as well. Body contouring surgery, getting that booty right. So body contouring surgery can encompass a lot of parts of our body. This is a combination of a procedure that comes from BBL or Brazilian butt lift and the contouring procedures that are performed after weight loss surgery. Right? So when someone has weight loss surgery or has lost about 80 pounds, that's usually the threshold that insurance holds tissue removal at, then they qualify for these procedures that remove excess skin and excess adipose tissue where it's no longer needed and where it might be causing some like rashes and discomfort. Body contouring surgery is also cited in the WPATH SOC 8 standards of care as a gender-affirming surgery that is medically necessary. This helps folks fit in clothes. This helps folks address so many things about their daily ways that they work and that they see themselves. For a lot of folks, it makes the difference between taking 2 hours to be able to get ready to go out and go anywhere and just being able to get up and go. These can include liposuction, fat grafting, and fillers, and or implants as well. Gonad surgery. Removing the gonads, so any of the reproductive organs may be removed as well. This can be an orchiectomy or a hysto. Hysterectomies may also include bilateral oophorectomies, which means that they would take away the ovaries. Patients can also leave one ovary. So if they're not sure about their access to testosterone long term, if there's issues with medication adherence, or they're just not sure about their future plans, they can leave one ovary, and that will stabilize them enough that we don't have to worry about osteoporosis or bone degeneration or any of that later on in the future. So for folks that have a hard time with that, that might be a good option. Usually gonad surgeries are required for patients that are about to have genital surgeries. Hysterectomy and oophorectomy is only required if what I call closing the front hole, the front door, which is the front hole, right? So if a patient is going to need cervical or ovarian cancer screenings or might still have that in their future and is planning on having a surgery that includes vaginectomy, the surgeons usually require for the patients to have a complete hysterectomy and oophorectomy so that if they wouldn't have to make a total abdominal incision to address that. We also wouldn't have a way to swab if that was needed in the future or anything like that. So usually they're required. It's very surgeon specific, so our go-to is still ask your surgeon, and then we can go from there. And genital surgery. So a lot of folks call this bottom surgery as well. There's a lot of things that go from the bottom, and there's a lot of places that we can name starting at the top, right? So genital surgery can include vaginoplasty, it can include labioplasty, metoidioplasty, vaginectomy, phalloplasty, and then it can also include things like urethral lengthening and glandsplasty for folks that have had phalloplasty. Vaginoplasty, I'll talk about those genital procedures here in a minute, but vaginoplasty and labioplasty are often sought out by trans femme folks. There's a couple of different techniques for vaginoplasty that are available across the country. In general, the wait time for genital surgery right now varies vastly across the states. There are some surgeons that have wait lists of about 2 years in order to get even into consultation. The average wait time for a consultation is about 6 months to a year to see a genital surgeon for the first time. Usually the process to see surgeons for genital surgery also includes meeting with a patient navigator where they talk to you about your expectations, they talk to you about the techniques that the surgeon does, and they make sure that you match up with what you're looking for and what they have. There are a lot of patients that'll do research online or talk to a lot of friends, and they'll be like, no, I'm for sure going with this surgeon. I know, I'm just gonna use what they say, I've seen their dicks online. I gotta go there, right? And so they're ready. And then they meet with them and they're like, I can't go there. I can't do that with that person. She didn't even talk to me. She didn't even look at me. And I'm like, oh, great. Okay, let's find a different surgeon. So when I talk to patients about surgeons, and this goes for all the procedures, it's like dating. 2 to 3 different surgeons to start. Get some feelers. You know, you're going to meet someone for coffee at your consultation. You're not going to go, sign the prenup right now today. So go in there and ask them questions and be open to it not working out. For some patients, it's the front desk staff that they can't even get past. And they're like, yes, I love the surgeon, I love the doctor, I love this provider, but I get in a fight every time I go into that lobby. Okay, what can we do to work that out? Do you still want to go see that surgeon? Do you want me to contact them and see what we can work out? Or, cool, do you want to just give this other place a shot? We can make you 2-3 appointments at the same time. Consultation letters, which I'll jump into here in a little bit. So some surgeons still require letters for consultation in order to even see a patient going into consultation. This was a practice back in the day when insurance only covered either top surgery or genital surgery. And so there weren't very many variables that we would write in letters or very many differences in terms of insurance coverage. Now that there are several different procedures and several different options within those procedures, usually, or rather, insurance doesn't require the letter to get to consultation. And guidance suggests that patients shouldn't be asked for any letters or documentation until after the consultation. I'm not gonna be ready to sign my life away for you to cut me open if I'm just getting ready to meet you and I haven't even seen your results before, and here I am giving you basically my check because you're about to turn it into insurance. I know you are. So I'm not gonna secure your check until you secure my chest, right? And so that's what I let patients know. And a lot of times there's this idea of scarcity to accessing surgery or scarcity to getting into the OR. Depending on the states that we're in, depending on the areas that we're in, that can absolutely be true and be very valid. But something that I can tell you for sure is that these hospitals and these surgeons have seen the coin from this surgery. And if they can start operating in June of 2020 before we even had a whiff of a vaccine, they're ready to fight for us to continue to be able to bill for having surgery and be able to continue having gender-affirming surgery. It's obviously going to be migrating and changing in a lot of different ways as it is right now, but that's one of the things that we talk about. And then I'm going to keep pushing. Support letter, so that's the letter that is given of medical necessity that lines all the things that the patient wants, confirms that they've addressed all their barriers, that everything's well managed, and that they're ready to roll into surgery. And then lastly, surgery clearance. So the physical and lab work that clears the patient for going into surgery and being able to have surgery altogether. These illustrations that you see here on the right side are from Hillary Wilson. So this is the style of illustrations that you'll see for the facial procedures as well. This is a vaginoplasty illustration that you'll see here, and this is a phalloplasty illustration that you'll see here. And so here you see the closure of the vaginoplasty and how the anatomy lays after the closure is made. I really love this because it's color-coded for her vaginoplasty and her phalloplasty procedures. Her phalloplasty procedures also include the placement of the natal clitoral tissue, which for some patients can be buried or can be unburied. When it's unburied, it's left exposed at the bottom of the phallus so that there can still be sensation. And so patients that are worried about losing sensation or have a really high priority of maintaining sensation after surgery can still have access to it and still go through the entire procedure. Any questions so far? Cool. Am I melting anyone's brain yet?
Could you, sorry,
yeah.
Could you repeat that part about the last option if sensation is more important?
Sure, absolutely. So the buried or unburied clitoral tissue, and that's natal phallic tissue if patients don't like using clitoris. Phallic tissue is the same on all the bodies. On some folks it grows longer, some folks it doesn't. And so the natal phallus tissue can sit either just underneath the scrotum or underneath the base of the phallus itself. And so with transmasculine folks, they can choose to have the phallus created as a part of phalloplasty. So they have the entire phallus created, but they don't want a scrotum, they don't want a pump, they don't want anything else. They want, because they want to maybe maintain their front hole. They might like having front hole sex. They might love that sensation and having access to that, but they still want the aesthetic presentation of being able to have a bulge in their pants or looking down and having a phallus. Totally chill. We can definitely do that. And that's just a phalloplasty in it of itself, and then that's where you get to choose the add-ons. So urethral lengthening is the component of phalloplasty where they make it so that you can stand to pee. And then usually for that procedure is where they require vaginectomy because they use up the space in the vaginal canal to close it up, and they use that soft pliable tissue to extend the urethra and close it on through. There are some surgeons in California and in a couple of other places that also do procedures where it's a full phalloplasty, but it preserves the vaginal canal or the front hole. So there are some surgeons that are game to do urethral lengthening without having a vaginectomy. There's a significant increase in complications and in chances of complications with those procedures, and a patient really has to be the ideal candidate, but it is possible. Same with penile preserving vaginoplasty procedures. There are a few surgeons in the States that do offer those procedures for the same reason. Patients want to maintain sensation, patients want to maintain function, but they also want to have a vaginal canal. Same thing, we're able to reduce the tissue, reduce the space. I do give patients the caveat that we don't know the amount of space that will be there until the procedure happens. So they might not be able to take the size that they anticipated before. They might have to look at other pleasure options as well. But the options are definitely there and they absolutely exist. Like I said, I could give you all the options and all of these things all day long about all of these procedures. Cool. So our doula program is a program that's meant to walk patients through this process, to help support them through the process, and to recognize that patients need more information and places to process this stuff. The doula program itself comes from inspiration from the Camden Coalition in New Jersey, a coalition of organizations that are non-medical spaces that offer information and access to health information. We've integrated these community networks, and so they have a lot of our patient education information. We do events at their locations. We do a lot of collaborative education and stuff like that. This also helps us reduce the amount of ER visits and reduce the amount of other things that might kind of like fall off the plate of what a patient has going into surgery. I'm going to speed through this because we're running low on time, but this is a cool graph about the pandemic. So before the pandemic, we only worked with patients that were seeking genital surgery because of the amount of needs and time and things that come with coordinating genital surgery. This is amidst the pandemic, so this is from June to October, and then blue is 2019, and red is 2020. So this is even while we were in lockdown, the amount of folks that were requesting surgery and were having surgery per month. And so in 2020, because of how everything got rocked amidst the pandemic, we shifted and we started care planning for all patients that were having any gender-affirming surgery that they were being put under for. Because patients' aftercare was changing, their supports from out of town weren't able to be in town anymore. At the same time, we had a lot of patients that were street homeless that were then immediately being housed and now qualified to have surgery that we had been working towards surgery for a really long time. So we were navigating things going back and forth. At the same time, lots of folks from out of town were canceling, and so there were a lot of sooner dates available. So a lot of local people then got shot up months to years on the wait lists that they were on right away. And so this meant that we had to figure out all of their housing, food security, all of that stuff in a matter of months as opposed to the year that we thought we had or more time that we thought we had. So we shifted to care planning for all patients. And so this is our workflow that we have that we work with patients through now. And I'm not going to break it up totally, but to start, patients are paneled with an ongoing medical provider to make sure that they have someone looking out for them as they're going in and out of surgery. Then we ask the patient if they've gone to a consultation, and we give them the tools to attend a consultation with a surgeon and be sure they get the full array of their options. And then once the patient's ready to talk about surgery or has gone to a consultation, then we jump into care planning. And so patients going into consultation have the option of having a patient education session where we talk about all the decisions that we expect them to make in the care plan and we educate them about it. So this is why your nutrition is important after surgery. This is why smoking cessation is important after surgery. This is why, right, all of these things, so that they have time to sit on it, to see how it is playing a part in their life at that point, and then to see what changes, if any, they want to make their gender-affirming surgery experience as affirming as possible. What I tell patients oftentimes is like, sure, we could send you into surgery in 2 weeks, not know who's going to take care of you. You will have had surgery, but I don't know what infection you might have, who's going to wake you up, if you puke right after any of that. Or we can wait 2 months and I can get you into some emergency housing for 2 weeks and then roll you into another shelter for another month after that. And we know you have housing. We have a visiting nurse service coming in because they have an address to go to now. And we've connected all of these dots and you only had to wait 6 more weeks. Right? And so educating them on the impact that that'll make oftentimes helps the motivational interviewing when we're care planning move through because they have that foundation and we're collaborating for those decisions. So in 2021, we started care planning with everyone and offering patient education. So these are some of the interventions that we use throughout the process. So resources and advocacy. Some of our resources have been brought up during our time today. Pump is a really cool guide. It's a sexual pleasure and health resource guide for transmasculine folks and folks that like having sex with transmasculine folks. So it talks about screenings. It has a name your parts guide if people want to name your parts guide. It has a lot of illustrations and just really rad like essays and different things that come in. A lot of guidance for healthcare screenings and a lot of guidance for being able to provide support and prevention care long-term for transmasculine folks in there as well. And then we got together and we made TransAtlas. So TransAtlas is our online resource and registry of TGNB or gender-affirming resources in the New York City area. My usual recommendation for folks is when you're talking to patients about surgery, and we've created what we call a TGNB perioperative screener, where we get that preliminary information from folks, we made a Google form or a Microsoft form version, and now I just save all the names of surgeons from there. I go and I vet them, of course, but then that turns into our provider directory that I'm able to provide other patients and have a list of folks that people in the neighborhood are actually requesting and going to. And then by the same token, when someone gives me the tea about one of them, we go back and we let them know the tea that we've heard and we see if they've addressed it and we have those caveats on there. We also have visible TGNB staff as more than just the front desk folks. So we have clinicians, we have folks doing outreach, we have folks in development, we have everybody, not everybody is trans, but we have a lot of trans folks. And then the best reputation is a good recommendation. So the more that folks on the street hear about what you're talking about, trans folks will tell you the tea and we'll tell each other the tea all day long. So documentation. So as we mentioned, legal transition and documentation can come here and there. EHRs are the bane of my existence altogether. And so when we're writing letters for patients, when we're in session with patients and you're doing that, confirm the information for the documentation. And know that the name is correct, know that the information is correct. If someone is at the brink of updating their name and going through a legal name change, usually I recommend for them to go with the name that is on their insurance card and not update any of that information until all of that's been approved. So we're starting with the name that we're going on there. You can always put both names if they're between the two or if they have several names on their ID documents. Their ID might have one thing, their insurance card has another thing, and then their name on your chart has another thing. Put all the names on the chart of like also known as, also goes by, also this and this, and I've still been seeing this person for 5 years, right? And so just naming that. When I'm asking the patient for their names on things, I ask for the specific name. What is the name on your insurance card, right? What is the name on your ID? Because it's not about what's your real name or what's your fake name or any of that. It's about what's the name on the document that I'm looking for and what I need it for. And then for me, so for example, I would use, is your name on your insurance card the name that starts with a V, or is it the other name that starts with a G, right? Or is your name, like mine is Vib on my chart and then Vibiano legally. And so I'd be like, is your name Vib on your insurance card or is it the other name that starts with a V? Does that make sense? Last names only, so in person or calling them back to exam rooms, last names only. And then having an easy way to update identification information. Sometimes this can just mean having the printouts of the forms that they have at the DMVs of the different things that they can use for their IDs. City IDs can come in very, very handy in this kind of way, especially for patients that don't want to go in and through the whole legal process of updating their gender marker or their name fully legally. A lot of times city IDs or urban IDs can do that and can mitigate that with just a form. And so that can be really helpful in that kind of way. Language, I have a language link in there that talks about Spanish language terms that folks are able to use. Clothing and garments, everybody leaves everything on in the exam room unless we absolutely need to take it off, and then they can take it off for what we need to do, and then they put it right back on. This includes prosthetics, this includes undergarments, this includes every single thing that they want. Collaborating and reviewing for documentation. We write everything together, we let them know, and then especially through the letters that are required for insurance, like for body contouring, for example, we write about how the patient presents with a masculine presenting hip to waist ratio that is boxy and just like reading the shit out of them, right? Oops, excuse me. Reading them to filth, right? And that's not what we actually think oftentimes and what we're actually saying, but insurance needs to have all of this language about the patient's body shape, right? And what their goals are. And so letting the patient know, hey, I don't think you're super boxy and like you don't know how to dress yourself or any of that. We're just putting that language in here because that's what they got to hear, and I know that it's really hard for you. You don't have to look at this. I'm just going to let you know, right? And sometimes that can be the case too of like, I'm going to write you the letter, but let's not read the language. I'm just going to make sure I have your names correctly in this part so that you know, right? Same with denials. A lot of denials still come through with you've been denied for a sex change surgery or a sex reassignment, no matter what surgery they're requesting. And so that might come through, and that might still be something that gets there. And we've already talked about intersectional experiences. I didn't even get into our workflows. But you all have the presentation and you all have these things to work through. In a nutshell, to start a patient on the surgery coordination process, the 3 things that we for sure need that will totally throw them off and have them start over again if they were to change is the surgeon, their insurance, and their procedure. So they need to know who their surgeon is going to be, what procedure they're having next, and their insurance coverage for that procedure. That, once they start planning in that direction, then we can keep going in that way. If any of those 3 things change, any little thing off of that can throw them off track, and then they'll have to get new letters, and then they'll have to go to a new consultation, and then they'll have to, all of these things. So if they can get to those things before we get going and we get started, that usually helps. I've included a copy of our screener. We've used it as an online form. I highly, highly recommend using things like Microsoft Forms or Google Forms, especially for a lot of this information that EHRs aren't built to help us run reports on, like names of surgeons or facilities and resources that patients have access to or what those places are asking for. Like I can tell you which surgeons ask for letters going into consultation versus which surgeons will book you for a surgery date right at your consultation based on what we have in these Microsoft Forms. And so they can really come in handy, especially if your patient volume starts going up because people on the street are going to start hearing that you know how to plan surgery. Patient education. This is what we cover in the patient education information. Consultation letters, we let folks know that they're not to be used for insurance. It's just to let the surgeon know that the patient is ready to talk about surgery. We write all of the information that is required in letters up to saying the procedure plan and that the patient is ready for surgery. We say that the patient is gathering information about their procedure, and once they have a procedure plan, they will come in for a reassessment and be provided everything that they need. On the clinician side, it cuts down on letter edits and patients randomly calling you and saying that they need this, that, and the third different on their letter, or that they need to send it to a different office, or that they didn't get it, or any of those things. And then lastly, our care plan and our support letters. The care plan is really the bulk of a lot of what we do. I also include the document for our care plan as well. We cover a medical history, a general behavioral health history, the details about surgery, including the procedure plan, site preparation, and aftercare, and then the aftercare, so like where they're staying, who's taking care of them, and those elements. And the support letter includes it all. So once you have all of that and you say that the patient needs all of these things, that goes in the support letter, that goes to the surgeon, that goes to the insurance, and approves the whole process. We at Cal and Lord coordinate surgery with several different surgeons. We have 4 standing case conferences with 4 area surgeons that are our most popular surgeons. So on a monthly basis, I will touch base with those surgeons. We'll talk about complications that we're seeing coming in very often, and we'll talk about ways to mitigate that or to address those complications that we're seeing with folks. This also helps in terms of advocacy and area policy so that we can all get on the same page and be swimming in the same direction, if you will, for any policy changes or things that we need to see differently. And I'm just going to end there, and y'all can dig into the rest of my presentation that's on the portal on your own end. Does anyone have questions, comments, concerns? Yes, cool. I'll go here first and then you. Next.
Thank you for the presentation. One thing I was curious is how do you go?
You have a fancy mic.
Oh, okay. First off, thank you for the presentation.
Oh, it's not, I'm sorry.
Yeah, okay. That's okay. But I just wanted to know, how do you address substance use? Because that is a huge barrier to access to surgeons. So.
Yes, absolutely. So substance use, that question. So with patients, we have a harm reduction model as well. And so with some patients, it's a matter of, okay, the surgeons won't approve you for surgery if you have this, this, and this, right? And so a lot of surgeons will do serial testing even before. This comes up with cotinine also, with patients that have nicotine or that smoke cigarettes also, and it shows up on their pre-surgery clearance. And so we educate them before then. I let them know when they're going to be tested. I let them know the effects that it's going to have and what happens afterwards. And I'm very real with it. I'm very real about the bleeding complications, about the infections, about the wound vacs that they're going to have, about the things. With vaginoplasty, you're going to be dilating 4 times a day, and that's going to be taking so much more energy out, right? And then combined with that, we talk to the providers about pain management and medical interventions that we can use to help them with pain management and alternatives to pain management, and working collaboratively with providers. For some patients, we're able to do leave-in anesthetics or nerve blocks instead of using opioids or other kinds of pain medication. That's been very useful, especially things like the on-cue local anesthetic pump that works with folks, or with nerve blocks for top surgery. Those have been largely successful and are long-lasting medications that then the patient just has surgery, is able to recover, and then continues their ongoing medication otherwise. For some folks, it means that we have to enroll in some programs, and if they know that it's temporary for them, then they know that it's temporary for them. There have been quite a few studies that have shown that trans folks, our health significantly improves and stabilizes by the habits that we're able to build getting ready for surgery, or as a result of having to keep them up for surgery. So for some folks, it's enough to like, oh yeah, I stopped smoking 5 years ago because I had to for top surgery and I just never stopped again. But then there's also some folks that are like, okay, I have the day that I can start again if I have no complications. And we make a plan A, plan B, plan C, right? Plan A, you don't start until X day. Plan B, you have a complication. What do we do if there's a complication? Plan C, what do we do if you know that you're about to need some or about to use, or if you do use, right? And where do we go from there? And you have a question?
Yeah, do you have an LA or California equivalent of the Trans Atlas? And when you say city IDs, could you give examples?
Yeah, for sure. So I don't have a LA comparable to Trans Atlas in particular. I wouldn't doubt that there aren't some boards on the West Coast that have something like that. I would check in with the LGBT centers. They usually have a pretty good pulse on folks that would connect you to something like that. And then, I'm sorry, what was the second part of your question?
The city IDs.
The city IDs. So sometimes in so like in New York City, you can get an ID that's specifically for New York City as opposed to like a New York State license. And so in some cities, depending on the size of the city or area, you can get those IDs. This also, like this principle can also exist at your center or at your workplace in terms of being able to give the patient a photo ID that has their name and identity that corresponds to the way that they look now. So in a lot of ways, we can help keep patients safe because you're asked for a photo ID in so many places, and it doesn't have to be a state photo ID. It just has to be a photo ID. And if I were to show you my photo ID from 3 years ago, you're gonna say that's not you, right? And so just letting folks have a photo ID, even if it's from your local library, from your org, that gives a lot in terms of them being able to say that they are who they are.
We'll do one more question.
One more question.
Thank you. Definitely eye-opening. What I see is that like you've been able to do a lot, really. And that's what I see is addressing what the patient needs, and that's what somehow when I stand back and look at what has been my experience so far, and I may think, well, the patient needs first a shelter and needs food, but that's what I think the patient needs, and that's what I see that patients may need more than what they need to transition into their identity, that they're going to be more confirmed about who they are. But you've been able to find the shelter and all the other support that you need to. So that's I see that this is like a very concerted effort and like advanced in many ways, that you've been able to do it in New York. Somehow my question to you is, it may require even funding, which is like being so creative, but how you've been able to progress so far, really going really outside the box. So that's like, has your experience and the people you work with, and just how that happened. Somehow, apparently it's so easy, but I don't think that's easy.
Yeah, no, it's definitely not easy. And it definitely, I mean, it's a lot of stuff that we've seen working in other programs and that we've seen working for other populations that we've kind of just strung together in these particular ways, right? So there's been reasonable accommodations for folks that are in shelters to be able to have reasonable accommodations to heal from surgical procedures for a very, very long time. We're just able to find those policies and show them up front and be like, look, it's a surgery, so they need housing for this particular surgery. They need their own restroom for this kind of surgery. And having that policy and having that there, or being able to relocate them in that way. Same thing with things like peer support. The Promotoras program that started in rural healthcare has been really, really big for peer support and peer education about a lot of these things. So a lot of it is programs that already exist for like diabetes education, for hypertension education, that we're just putting a little trans sprinkle on top and bringing it in and being like, hey, we need that too. Hey, we need that too. Because we do in a lot of these places. Thank you all. I appreciate it.
Thank you so much, Deb. We're going to take a very quick 5-minute break, so we'll just pull up the next presentation so you have some time to go to the bathroom, get some more water, etc. Yes, it's in this hallway right there. Yeah. I'm so glad that you made it. Sorry about the travel. What was it? Thank you for so.
A nightmare, but I made it.
It's nice to meet you, by the way. Yeah.
I normally have people fun inside, but I was like running around so much I didn't even bring one
I
with
think
me.
it's about half and half of the conference, so whichever. Thought maybe I could. Was it down?
I was so pleased to find that there was a printer in the lobby of
Oh,
my hotel down the street.
perfect.
So.
Perfect. And then we have a break after this, so we'll have time for you to have a full hour.
Okay, great. always over-prepare anyway and probably have way too many slides, but I imagine some of this stuff is probably covered a little bit already, so. Did Elliot take off already?
Yes, he did. But their presentation was okay.
Awesome.
So
Good.
loved it.
I've known Elliot for many years, but I've never seen them present. I was really sad that I missed it.
No, it was great, and they have such a like a calm
Yeah.
presentation voice. It was lovely.
Yeah, that's not me at all. I'm like yelling and very animated
We
usually.
appreciate diversity, especially in the afternoon.
That's fair.
I was just gonna mention, just for your, since you weren't able to make it this morning, let's see. We went over pretty extensively best practices for program use
Great.
this morning.
I'll skip it.
And then I think that was the only, let's see. I think that was the only thing that I thought may be redundant.
Great.
But other than that, especially the social determinants of health stuff, we haven't in depth covered.
Oh, okay, great.
How that's affected TGC communities, so
Okay,
I was excited to see that.
I will not breeze through that part then. Cool.
Let's make sure it's. Oh. Cool.
Do my notes come up on here too? Probably if it says, yeah. These are like slide decks I normally like co-present with other people, so the slides are probably going to say Andrew.
Sounds good, and we can probably start at 2:15.
Great.
How does that sound?
That sounds great.
Yeah, see, I know. Really? Yeah. It's kind of something to
And then just a quick reminder that those evaluations are at the end of your table, and we really welcome y'all's feedback. If you don't see one or there's not enough for your table, just let me know.
It's also on the
Kelly, should I go ahead? Cool. Hi, everybody. Whew, I've had a whirlwind 24 hours. I know I was supposed to be here earlier, but my flight back from Austin yesterday was delayed by about 15 hours, so I got into Philadelphia after midnight, had to go home, change out my suitcase. The airline also lost my suitcase, and then I had to pick it up this morning and get here. Anyway, that's why I'm late. But thanks for being here, and thank you so much for swapping times with me. I caught the end of your presentation. It was fantastic. I wish I could have seen the whole thing, but it's being recorded, so I guess I probably can later. So my name is Andrew. My pronouns are he, him, and his. I am the Director of Training and Technical Assistance at a program out of Philadelphia called Pathways to Housing PA. If you're not familiar with us, Pathways is a homeless services organization. We're based in North Philadelphia, and we use the Housing First model and harm reduction to help end chronic homelessness for single adults who are living with serious persistent mental illness and or substance use disorders. We've been doing that since 2008, and we have an 85% housing retention rate with the very same folks who were considered not ready for housing in other programs. We started with one clinical team serving about 50 participants in 2008, and today we have 8 clinical teams, and we're getting closer and closer to 600 participants every day. So we're pretty big. Many folks have reached out over the years and said, how are you doing this? What's in the secret sauce? And it was always like our clinical director and like a team leader that were running around trying to meet all the training needs. So we actually launched Housing First University in early 2020, right in time for the pandemic, to start, empowering other communities with these best practices to see some of these comparable results. So I started out at Pathways as an assistant team leader on a clinical team, a team leader on a different team, and then they said, Andrew, build a training institute. And I said, I'm a social worker. I talk to people about food stamps and their feelings. I don't know how to do that. And they're like, you'll be fine. And now we're working with people all over the country and sometimes internationally, so it's going really well. But prior to coming to Pathways, I worked at a program in Philadelphia called the Morris Home. It's operated by Resources for Human Development. And as far as we know, Morris Home is the only inpatient residential drug and alcohol treatment program exclusively for members of the trans community in the country and possibly in the entire world, right? So there are rehab programs that are for LGBTQ people, but a program specifically for trans, gender nonconforming, and non-binary folks, we're pretty sure Morris Home is the only one. So when I went to social work school and thought I was gonna be doing macro practice, I was out for a couple of months, and then the program director called me up and said, we need a therapist. And I said, that's not what I studied. And she's like, you'll be fine. And I couldn't say no because it was really a once-in-a-lifetime opportunity to be involved in developing best practices for serving behavioral health needs of trans folks. I myself am a person of trans and queer experience. I'm also a person with multiple mental health diagnoses and a person in long-term recovery from a substance use disorder. So it was really an opportunity I could not say no to. So I was the lead therapist at Morris Home for a number of years, and when I moved to Pathways, one of the reasons I did that was because at Morris Home at the time, we only had 8 beds, right? So I could help 8 people at a time. And the work was incredibly powerful and meaningful, but I was really curious to bring some of that knowledge to another larger organization and to see if I could, kind of spread my trans agenda around a little bit. And now that I'm training folks nationally and sometimes internationally, I get to sprinkle some of the trans stuff all over the trainings that I'm doing. So if somebody calls me about harm reduction or about housing first, we're gonna talk about the needs of the trans community. So I was delighted to be asked to be here for this presentation today. I've attended many of these conferences only virtually, so this is my first time in person, and happy to be here with you all. So that's just a little bit about me and kind of what brings me here. So we're going to talk about behavioral health. I have some learning objectives. Probably I'll tell you more than these things, but ideally at the end of the hour, you'll be able to recognize some common challenges impacting trans and gender nonconforming behavioral health. I used the acronym TGNC plus today. I don't know if I made this presentation next week, it might have been something different, but trans, gender nonconforming, plus anybody else who's not cisgender is essentially who I'm talking about. Second, describe the role of intersectionality on behavioral health outcomes. And then lastly, maybe name 3 ways that you can make your service provision more affirming to non-cisgender folks. I probably have way too much content to really get into all of this, but just raise your hand if you're doing behavioral health work. That's really what I want to know. All right, about half the folks in the room. Raise your hand if you're not a behavioral health worker, but you're working in a setting where other people are providing behavioral health services. All right, now we covered everybody. Great. So why do we need to know this stuff to begin with? I'm talking really fast. I got a lot of content. Like I said, I always over-prepare. So if you have a question, like jump in and ask it. Otherwise, I'm just going to keep steamrolling through my 32 slides. So why do you need to know this stuff? Well, there's an estimated 1.4 million people in the U.S. who identify as transgender, and another 1.2 million people who identify as non-binary. Normally in trainings like this, there'll be at least one person in the room who's like, I've never worked with a trans person. I said, yes, you have. You just didn't know that because the person didn't feel safe disclosing their identity to you, right? So if you have not yet encountered a trans or gender nonconforming person in the workplace, either as a client or a colleague, first of all, hello. We're in a professional workplace and I am a trans person, so there you go. But odds are you already have. You're already working with trans and gender nonconforming folks. So healthy communities are made up of healthy people, and healthy communities include trans and gender nonconforming folks, so we need to know this stuff. So I was a little worried that maybe I was like repeating a bunch of information y'all had heard earlier, but Kelly told me we have not really honed in a lot on social determinants of health yet. So I do want to spend a minute here because this is really important stuff, right? So we have these 5 different areas. These are our social determinants of health. Economic stability is kind of how our financial resources or our lack thereof impact our health, right? This includes things like our socioeconomic status, our income, cost of living, and this area really looks at how poverty, employment, food security, and housing stability all intersect to impact an individual's health. Education, that's the connection of education to health and well-being. So things like our early childhood education and development, high school graduation rates, enrollment in higher education, language, and literacy, all of these things are tied to health outcomes. Social and community context, that's the area that looks at the connection between health and well-being and experiences of community, civic participation, discrimination, workplace conditions, and incarceration. Neighborhood and built environment, how a person's housing, neighborhood, and environment influence their health and well-being. What's the quality of their housing like? What's their access to transportation like? What's the availability of healthy foods in the neighborhood? Air and water quality, levels of neighborhood crime and violence all play in to this area. And lastly, health and healthcare. So do individuals have access to healthcare? Do they have access to trans-affirming primary care, health insurance coverage that actually meets their needs, and health literacy to be able to navigate all of those health services, right? How does one's understanding of the health services and access to them impact someone's health? So when we look at how this applies to trans, gender nonconforming, non-binary folks, here's some of what we see. Have we talked at all about the 2015 U.S. Trans Survey today yet? Okay, so we all know what that is. And we know that another survey has been conducted and we're gonna have new updated numbers for you soon, but right now we're still working on these 2015 statistics. But according to that survey, we found that trans people were 4 times more likely to have a household income of less than $10,000 per year, right, compared to the general population. I'm thinking economic stability area right now, top left. Employment. Survey respondents experienced unemployment at twice the rate of the general population at the time of the survey, with rates for Black transgender people being 4 times the national rate and other trans people of color being at elevated rates. 90% of those surveyed reported experiencing harassment, mistreatment, or discrimination on the job, or took actions like hiding who they were in order to avoid those things. 25%, so over 1/4, reported they had lost a job due to being trans or gender nonconforming, and 50% experienced harassment in the workplace. Housing and homelessness, 30% of trans folks report experiencing homelessness at some point in their lives. The 2020 State of Homelessness edition that came out from the National Alliance to End Homelessness reported that there were increases in both sheltered and unsheltered homelessness for pretty much every subpopulation between 2016 and 2020, right? But most of those increases were about 8 to 35% at most. For trans people, however, homelessness, sheltered homelessness increased by 88%, and unsheltered homelessness increased by 113%. I've run that statistic before, and people go, "What happened in 2016?" We know what happened in 2016. There's a presidential election. Anyway, education. I think this statistic might be specific to Pennsylvania, where I'm from. But those who expressed a trans identity while in grades K through 12 reported 78% reported harassment, 35% reported physical assault, 12% reported sexual assault or harassment, and then 15% of trans students in K through 8 said the harassment they experienced in schools was so severe that it led them to just drop out. They couldn't go back to school. Health and healthcare. 22% of respondents to that 2015 trans survey said they did not see a doctor when they needed to because of fear of being mistreated as a trans person. 33% who did see a healthcare provider within the last year said they had had at least one negative experience related to being trans. So this included things like being refused treatment, being verbally harassed, being physically or sexually assaulted, or having to teach the provider about trans people in order to get appropriate care. I had a tonsillectomy maybe like 7 years ago, and one of my friends who's a nurse asked me what my tonsillectomy had to do with my transition. A healthcare provider, just saying. 12% of trans people in that 2015 survey, it doesn't. We get that, right? Okay. They're unrelated. Trans people have tonsils too. It's just clearing that up. Okay. 12% of respondents to that survey said that a professional, like a psychologist, a counselor, or religious advisor, tried to stop them from being transgender. And about 41% of respondents to that survey said that they reported attempting suicide at some point in their lifetime, right? 1.6% of the general population reports a suicide attempt in their lifetime, compared to 41% of trans people. I think it's important to name that I'm included in that statistic, right? And that these are experiences that impact trans people of all kinds, right? It doesn't matter what race you are. I mean, these things very much matter, and we're gonna talk about that, but I'm gonna say it doesn't matter how privileged you are as a member of the trans community, these statistics are coming for you as well, right? We're familiar with this idea of the school to prison pipeline, right? So how does that actually play out for trans, gender nonconforming, non-binary folks? We just talked about students experiencing disproportionate violence, harassment, and discrimination, which makes them less likely to graduate high school or pursue higher education. Concurrently, we also see a lot of trans, gender nonconforming youth and young adults who are experiencing family rejection for the first time, which often leads to your first experience of housing instability or homelessness, right? My partner for a long time worked in the Juvenile Justice Center in Philadelphia. She worked for Children's Hospital of Philadelphia doing HIV risk reduction with incarcerated youth, right? Many of the trans youth who were incarcerated were there basically because they had nowhere else to go. They hadn't even done anything wrong, right? Their family said, nope, not under my roof, you gotta go. They end up in a group home, somebody makes fun of them or teases them for being trans, and then there's nowhere else for them to go, and they end up in a correctional facility simply because there's nowhere else to house them, right? It's called like failure to adjust or something. And so seeing folks, strictly just because of family rejection, experiencing incarceration without any actual charges, right? Getting sucked up into the system. So if you don't have an education, if you don't have a family, if you don't have a home, a safe place to stay, it's going to be pretty hard for you to get a job. You usually need to put an address on a job application, right? You certainly are probably not going to have an ID because that costs money, right? And if you don't have a job and you don't have family that's supporting you, you're not going to be able to pay for that ID. You're not going to be able to pay for the name or gender marker change that you need or access those services. It takes a lot of kind of social capital and time and energy and resource navigation, right? So we see those higher rates of unemployment, but we also know that folks who are able to get a job are more likely to be harassed on the job or fired for being trans, right? So this is why we see an overrepresentation of trans and gender nonconforming people engaging in survival economies, right? Engaging in sex work, engaging in selling drugs for income to meet their basic needs, right? If it is the difference between having a roof over your head and being able to pay for a motel room that night, right? Or sleeping on the street, being able to buy yourself a sandwich or not, going hungry, right? Folks are going to do what they need to do to take care of themselves. Now, trans communities are already over-policed, right? Having worked at Morris Home, I cannot tell you how many times a member would come home, particularly a trans woman of color, saying that she got stopped and harassed by police on the street simply for walking around in public being a trans woman, right? And God forbid you also have a condom in your purse. Police then searching you are going to assume that you're engaged in sex work, right? Just because you're out in public, visibly trans, right? So there's already this over-policing of trans communities, but if folks have higher rates of engaging in survival economies, we then see an over-representation of folks in jails and in prisons, right? So it's not about trans people are making worse decisions than everybody else, and that's why we're seeing more people incarcerated. It's trans people are doing the best they can with what they got to get by and survive in the world. So there's all these political barriers, right, playing into kind of these social determinants of health at the same time. We still have a lack of federal level non-discrimination laws. We have marriage equality. Great, that helps some people a little bit, but right, we still can discriminate against people in housing, right? People will push back on this and say, well, we have the Fair Housing Act, right, which is like an ordinance, it's some guidelines, but how that actually plays out in practice, right? So you are a trans person, you've been discriminated against in housing. Do you have the social capital and the resources to do anything about it, right? There are not actually laws, and we have seen from Roe v. Wade, right, that unless something is codified into law, it can be taken away pretty easily. And so right now, the only federal level laws that we have protecting trans people are in marriage equality and in employment non-discrimination, right? And that just happened in June of 2020. But discrimination in every other area is still fair game, right? The Equality Act has been in Congress since the 70s. I was born in 1982. The Equality Act is older than I am, right? So we're still really lacking protections. Conversion therapy, still legal in many places, completely scientifically debunked. Every major medical association, counseling organization has said this is incredibly harmful, increases suicide rates. Please don't do this, yet it's still legal in Pennsylvania. It's outlawed in Philadelphia and certain other counties. It is outlawed in the state of Maryland, I checked, which is great, but there are still many other states where conversion therapy is legal, right? Extremely harmful. It was banned here, Maryland, in 2018. Let's see, what else we got? Bathroom bills. Big problem, right? We're just like, oh, that's a silly little thing. People will never notice. Go in the bathroom you want, right? Well, that's maybe if you pass, right? Or if people are not scrutinizing you when you walk in the door. But I can say in the first couple of years of my transition, there was no bathroom that felt safe for me. I go in the women's room, I'm gonna get screamed at. I go in the men's room, I worry that I'm gonna get beat up, right? And I am a person who is white, right? And so when we think about the intersectionality experiences of trans people of color, of transgender women, of black trans women, these have real major consequences, right? And so when people don't feel safe going to the bathroom and they're walking around holding their pee all day, people get urinary tract infections and kidney infections. There are actual real health implications to these laws. We see a lack of social programs targeted to or appropriate for trans and gender nonconforming folks, right? Philadelphia is known all over the country as a hub of resources for trans people, right? But the whole reason I became a trainer in the first place, this was never part of my plan, but when I worked at Morris Home, every time I tried to make a referral for someone, I'd get somebody on the phone who said, we don't know how to work with trans people. We've never done that before. What does that even mean, right? So I have a trans woman who's in an intimate partner violence situation, and I can't get her into a support group because the agency says, well, we can't promise that it'll be a safe space for her, and like the other women in the group are not gonna know what to do, right? And so she just doesn't get that resource. So myself, my colleagues just started going out and training other agencies for free out of necessity to make sure that our participants, our members, could get the support services that they need, right? So we still have a long way to go, right? Like one program per city for per issue is not enough. What happens if somebody burns their bridges at that program, right? Think about other behavioral health needs and folks who have gone to like 6, 7, 8 rehabs and been banned from all of them. Well, they probably still have 6, 7, 8 more rehabs to choose from. When there's only one rehab in the country that's exclusively for trans people, it's not enough. We also have a shortage of providers who are knowledgeable and culturally competent in trans and gender nonconforming needs, right? Happy that y'all are here today. Please take some of this information back to your colleagues and coworkers. This is not like a one-shot deal where you're gonna learn everything you ever need to know today, right? I am learning new things all of the time in this work. My partner who works with trans youth, every time she runs a group with them, comes home and says, have you ever heard this word before or this term before? Like, our language is constantly evolving. We're finding new ways to describe our experiences, right? And so we gotta keep up with this. There's always more kind of work to do in this area. Even for someone who is trans myself, I'm not inherently born with all of this information and knowledge. I've learned it from studying and from talking to other people. So we gotta kind of continually be engaged in that process. You can't just absorb the information from working in an LGBTQ clinic, right? Like, you've got to do the work. You've got to unpack some things for yourself and figure out what it means for you to be providing culturally competent or culturally affirming services. And then limited or no access to legal processes for documentation reflecting gender identity, right? So I live in Philadelphia. I've been able to get my name legally changed in Philadelphia. I was able to get my gender marker changed on my ID. We've actually made that a lot easier in Pennsylvania. Before, you needed to have a doctor write you a letter. Now you can just go to the DMV and pay $37.50 and change your gender marker, which is great. But I was born in Texas, and my birth certificate is from Texas, right? And I haven't even attempted to deal with that, because I think what I have to do is go see a judge in Philadelphia and have the judge write a letter to a judge in Texas to say, can you please change Andrew's birth certificate? And the judge in Texas might be like, sure, or might be like, no, thank you. And I don't know that I have any recourse after that. I don't know, very complicated, right? But again, like, I have a master's degree and I haven't even attempted to do this, right? Like, I am a well-resourced, privileged person. And so thinking about other folks who are experiencing poverty, who have serious mental illness, who are unhoused, right? All of these things become more and more complicated. This is current as of yesterday. So the ACLU currently tracking 474 anti-LGBTQ bills in the United States. There's a hyperlink in the presentation where you can go to this website and filter it by state. So we've seen a really increased amount of legislation, anti-LGBTQ legislation in recent years. Most of this is targeting trans kids, trans athletes, and trans women specifically, in healthcare for trans people, right? So nearly 500 bills at various stages of legislation in about 44 states. Some highlights: Florida has proposed removing trans children from their parents, or removing children from a home where the parents are trans identified, right? Multiple states have criminalized life-saving medically necessary health care. 18 states have banned trans kids from sport, right? I'm sure some folks have also heard about the law. It was defeated in Tennessee, the proposed law that would ban drag in public, right? And if you were caught in drag, which is specifically and purposefully very vague, right? So that is being a trans person being in drag, or is it drag performance, right? Kind of left up to the individual arresting officer to decide, right? And so this law in Tennessee that was defeated, thankfully, but if it had passed, someone who was arrested for performing drag in person would be charged with a sex crime, right? At the same time, Florida, like a month later, passed that law that said that sex offenders with crimes against children, punishable by death, the death penalty, right? These things are not happening in silos. Like, these state legislators are in conversation with one another, they know what they're doing, and it's an incredibly dangerous time for trans people, right? Is anybody in here from Texas? Cool. 52 of these are happening in Texas, right? I was born in Galveston. I've got family down in Texas. My little sister lives there. That's why I was there. Let's see, 48 are from Missouri. Anybody from Missouri? Most of these are southern states. 35 from Oklahoma, 29 in Iowa, 26 in Tennessee, and 25 in Mississippi. But don't get me wrong, I mean, we've got these Northeast states too, right? There's 3 in Pennsylvania, there's a whole bunch in Ohio, right? So, I mean, there's not really any place right now other than like Illinois and New York State that is safe for trans folks. This has a huge impact on our mental health, right? These things are not happening and trans people are just going on business as usual. I can speak for myself and say that my anxiety is through the roof, right? And there have been some studies on the impact of this, not a lot, but we've seen intro of bills criminalizing trans folks and trans rights linked to suicide and depression-related web searches, right? And simultaneously, defeat of those bills has been linked to fewer depression-related web searches, right? When Texas first introduced a bathroom bill in 2017, the Trevor Project reported a nearly 50% increase in calls from trans youth, right? 85% of the trans youth callers reported that their mental health had declined since they started paying attention to anti-transgender legislation, right? And then on the flip side of that, we see that structural level trans inclusion, so protections from discrimination in schools, the ability to change your name and ID on your documents, right, your name and your gender, predisposes better mental health, less alcohol consumption, and more recent healthcare utilization among trans individuals, right? So this stuff is not happening in the government and no one's paying attention. Before these laws are even passed, and even if they get defeated, they're still having a negative impact on the health and wellness of trans people that are aware of this stuff, that are paying attention, right? So we've mentioned intersectionality a little bit already, right? A term founded or coined by Kimberly Crenshaw in 1989 to explain the oppression of African American women, right? And the idea is that people are experiencing harms at the intersection of the different components of their identity, right? Our identity markers are not independent of one another, and when multiple oppressions converge, that oppression is complex and has increased implications for those individuals, right? So all of this stuff that I'm talking about, changing your name or your ID documents, being able to see a healthcare provider, whether or not you're housed, right? If you're undocumented, how does that impact your ability to legally change your name if you want to, right? If you're non-English speaking, how do you find a doctor who's trans-affirming with whom you can also communicate, right? If you have a psychiatric disability, it might be harder for you to receive gender-affirming hormone therapy. If you're experiencing poverty or homelessness, do you have the resources or the ability to change your name, your gender marker, or your identification documents, right? Even amongst trans people, we obviously see privileges for those who are masculine presenting and the impact of trans misogyny, right? When we look at the poor health and social outcomes of trans women, particularly trans women of color and Black trans women. I pulled some of those stats just to be able to look at them, right? So transgender people of color and specifically Black, trans and gender diverse people experience deeper and broader patterns of discrimination than white respondents in the US population when we look at that 2015 survey data, right? Based on those statistics, we see that about 38% of Black, trans and gender nonconforming people are living in poverty, compared to about 12% of the general population and 24.1% of non-Hispanic Black adults, cisgender Black adults, right? So 38 versus 24%. 20% of Black, trans, and gender nonconforming people were unemployed, compared to 9.6% of cisgender Black adults and 5% of the general U.S. population. 20% of Black, trans, and gender nonconforming people were uninsured, compared to 11% of cisgender Black adults and 11% of the general U.S. population. And in regards to suicidality, about 9% of Black trans people reported attempting suicide in the previous year, compared to 3.7% of Black cisgender adults and 0.6% of the general US population, right? We know specifically HIV rates as well, right? The 2015 NCTE survey said that about 1.4% of respondents were living with HIV at the time of that survey, compared to the general US population of 0.3%, so nearly 5 times the rate of the general population. But when we look specifically at transgender women, it was about 3.4% for trans women of color, and nearly 1 in 5 Black transgender women were living with HIV, about 19%. So I had to bring in some of my homeless services slides, right? Because this is what I talk about all the time. You've seen this, Maslow's hierarchy. We're all familiar with this, right? We also know that Maslow stole these ideas from indigenous First Nations, Native Americans, didn't come up with them himself. Just want to put that out there, right? But this is that idea that when our basic needs are not met, right, we're not going to be able to work on our emotional well-being. If we know that most trans folks are struggling with these 2 base layers of the pyramid, we're not having our physiological needs met, and we're certainly not having our safety and security needs met, right? How are we going to teach someone as a behavioral health worker to not be hyper-vigilant, right? Because it's causing problems for them when being hyper-vigilant is literally keeping people alive right now, right? We're teaching people skills that are contraindicated for their survival, right? And so all of these laws, policies, social determinants of health have real-world implications for how people are living their lives and what their mental health looks like. So when I hear a well-intentioned provider say, but I treat everybody the same, isn't that good enough? No, it's not. Life doesn't treat everybody the same, which is what we see from all of these statistics, right? The point is we can't treat everybody the same if we want to be providing good, equitable care that actually meets people's needs. I'm a social worker. I'm a licensed social worker. Social work practice is about promoting the inherent worth and dignity of every individual, right? My trans identity is part of me as a whole person, right? Gender identity, sexuality, these differences are part of the whole person. Sociologists have argued this idea, people who claim not to see race, right? Folks who say I'm colorblind. This is actually incredibly harmful in their work with people of color, right? The same goes for LGBTQ folks, especially trans folks. If we're pretending that marginalization and different social barriers aren't existing, that they're not part of what people are seeing and experiencing every day, then we're denying people their full selfhood, right? So that's kind of the backdrop for here's all the problems, and now I'm going to tell you a little bit about what we can do to I think the policy discussion we're going to have after this, maybe we'll get at some of the structural changes we can make upstream to prevent some of this, but as behavioral health workers, a lot of the times what we're doing is responding to the trauma that's already occurred, so I'll give you some advice on how to do that. The first place is language, obviously. Avoiding gendered language when possible, we already know this, right? Not good morning, ladies and gentlemen. Folks don't want to hear that, right? Can we just say, good morning, friends. How are you doing? How are y'all this morning? Sometimes I just slip back into my text as y'all because it's easiest, right? And I'll say from working in behavioral health care, specifically supporting the needs of people who use substances and being a person in long-term recovery myself, right, I'm a member of a 12-step fellowship. I'm a diehard harm reductionist, but I'm a 12-stepper by night, right? And 12-step programs use super binary, super heteronormative language, right? We talk about an addict is a man or a woman whose life is controlled by drugs, and the men got to get with the men, and the women get with the women, and that language leaves a lot of people out, right? So I've seen a lot of folks who have come through the Morris home who say, I don't really get with 12-step programs. I don't feel like I'm a part of that, right? I feel excluded. There's not language that represents me. So don't push back on people. Let folks experience that and explore other avenues. 12-step abstinence-only recovery is not the only way, and it's not for everybody, right? I'm also really careful about using the word clean, right? I prefer to use the word sober or abstinent to describe a period away from using substances, because the word clean carries extra stigma for folks who are overly impacted by HIV, right? So if we can default to using the word sober or another word other than clean, which is just super stigmatized, it's always best. This is the meat and potatoes right here, our clinical practices. The first thing that if you don't take anything else away, someone's trans identity is not necessarily the reason they are coming to you for services, right? I didn't need a tonsillectomy because I'm a trans person, right? I don't experience depression just because I'm a trans person, or anxiety just because I'm a trans person. Sometimes people use drugs, and it might have to do with their discomfort around their gender identity. It might also just have to do with the discomfort of the way the world treats them as a trans person, or it has nothing to do with those things at all, and they just like using drugs, right? So unless somebody tells you they want to center the narrative of their trans experience in their treatment, please do not center that for them, right? Whatever somebody's presenting problem is, take them at their word for that. We can't assume that gender identity is just like the root cause of everyone's struggles, and that's why they have a substance use problem, or that's why they're suicidal, right? I actually had a therapist when I was 19 years old who told me the reason that I was so depressed was because I hadn't come out to my parents yet. And so even though I didn't feel ready, the therapist was like, you should do this, so I did it anyway, and guess what? I was still depressed afterwards. It was not the reason I was experiencing depression. Trans people experience all kinds of emotions and all kinds of behavioral health concerns that are not necessarily related to various clinical diagnoses and problems. They might be, but they might not be as well, right? Acknowledging past traumatic experiences with providers, right? We know that a lot of trans and gender nonconforming people delay seeking treatment because they're afraid of the provider based on past experiences they've had or stories they've heard from their friends, right? Word gets around. If you're an affirming provider, your wait list is gonna fill up real fast. And if you're a crappy provider, like don't expect you to treat one trans person badly, everybody else in the community is gonna hear about it and they're gonna cancel their upcoming appointments, right? So I think it's important to acknowledge, right, like somebody who has had these previously bad experiences is not gonna trust you right out the gate, right? It is not like it's like the earn respect and earn trust. You're not automatically entitled to it because you have a bunch of letters after your name, right? Folks will know through interacting with you, even if you're not perfect, right? Like even if you flub a word here or there or use an outdated term, right? Generally, folks can tell if you are trying, if you are coming from the right place, and if you've done your homework, even if you're not perfect 100% of the time. But not expecting folks to be like ready and willing to divulge their entire biopsychosocial history to you on day 2, just because they've entered into, a therapy program with you. I think it's also important to note that trauma lives in our bodies, right? Physical manifestations of trauma for people with complicated relationships to their bodies is going to be even more complicated. So we need to think about this when we're talking with folks who have experienced interpersonal violence, especially as it relates to their gender identity, when we're thinking about folks with eating disorders, right? When we're thinking about offering different kinds of somatic therapy to folks, like, is that something somebody who feels discomfort with their body, is that something they're wanting to engage in or they're ready to engage in? And really just being mindful around that. When I think about programs that are dormitory style programs, like a residential program, right? Letting folks self-select into, do they want to be in the men's dorm or in the women's dorm, right? Do they want to have their urine drug screen procedure done by a male staff member or a female staff member, right? They might choose to sleep in the women's dorms, but maybe they want their UDS done by a male staff member, right? These things can be fluid depending on the person. We don't just shove somebody in a corner based on how they present and assume everything's good. We gotta ask these questions. Another thing I see programs doing sometimes is using isolation disguised as safety, right? Well, we don't wanna put you in the men's dorm because you'll be unsafe, so you get your own room, right? Well, recovery happens in community with other people, right? It doesn't happen in isolation. We have group therapy for a reason. So if we say, well, you don't fit in the men's group and you don't fit in the women's group, so you're gonna have extra one-on-one sessions with the therapist instead, right? We're well aware that separate but equal is not a thing that works, right? So talking to folks, figuring out where they're gonna be most comfortable and making those accommodations. And if folks change their mind, right, they try going to the men's group for a while and they say, actually, I don't feel very comfortable here, respecting that and then letting them switch, right? And if other cisgender folks in the program are having a problem with that, then it's our job to kind of provide some information and education to help get everybody on board, because everybody deserves the same level of treatment, right? Another thing, that's particularly relating to like drug and alcohol treatment, substance use treatment, is remembering that LGBTQ social norms often really heavily include or focus on drinking, right? Alcohol and tobacco are aggressively marketed to the LGBTQ community, right? A lot of times, queer folks, trans folks meet their first other trans person at a gay bar, right? So when your entire social life has revolved around partying, right? How do we help folks build new safety nets, build new social networks outside of substance use settings, right? I think can be a struggle for folks. I want to say including chosen family in treatment. Oftentimes programs will say, well, it's only somebody's like biological mom or a sister who can come to this treatment session. Trans folks are really good at creating family systems and support systems for themselves, especially when they've experienced family and community rejection or rejection from communities of faith, et cetera. That's why I included our picture of Marsha P. Johnson and Sylvia Rivera, right, who ran STAR, the Street Transvestite Action, what's the R? Revolution. Where they took in street kids, right? Homeless kids, sex workers, trans homeless kids and sex workers, and built family units and took care of one another, right? These bonds are often much more meaningful than folks' relationships with their biological families. So asking them, who's an important part of your life? Who are your support network folks? And bringing them into the treatment process as much as possible. And then lastly, make sure that you are listening to people. I've detailed all of these horrible things going on in the world impacting trans people, but that does not mean that trans people are just helpless victims that don't know what they want or don't know what they need, right? So listening to folks, trusting that they know what's best for themselves, that they know what their wants and needs are, that they are the experts on their own lives, right? And then empowering them to make the decisions that best fit their life and their own needs. Occasionally I've had folks who really struggle with the idea around like treatment planning, especially when they haven't worked with a lot of trans people in the past. So this will be in the slides that you can look at whenever you want. But the idea around like, you are not necessarily somebody's gender therapist, unless you are, right? Like if that's what you're trained to do, great. But if you're trained to be a substance use counselor, then you're there to talk about substance use. Not necessarily somebody's gender identity. So what is the client's most pressing issue or issues, right? Is it that they need to unpack their gender identity? Maybe not, right? What is it that they have come to you for? It's probably to talk about their relationship to substances, right? You can also ask, are there gender-affirming resources you need outside of this environment? Great, let me go pull those for you. But the behavior that they're presenting for assistance with may or may not be related to their gender identity, so you gotta figure that out pretty quickly, right? If it is, you might need to pull in some extra support around call me up. I do case consultations, right? There are lots of people out there who can assist you with this. Don't try to forge into that territory all on your own if you're not trained to do it, right? But also stay in your lane. If that's not what somebody needs help with, that's not what their presenting problem is, then don't make it an issue. I hear you talked about pronouns already, so I'm going to skip this. I do want to say a little bit about microaggressions. The best definition I ever heard of microaggression, there's the fancy dictionary definition, but the colloquial definition I like to use is death by 1,000 paper cuts. You get one paper cut, it's very uncomfortable, don't like it, stings, right? Not a big deal though, not the end of the world. You get paper cuts all day long, right? Especially you're a person with multiple intersecting marginalized identities. So you're getting paper cuts because you're trans, you're getting paper cuts because you're a person of color, you're getting paper cuts because you're trans feminine, you're getting paper cuts because you have a mental illness, right? Then eventually we're bleeding out all over the table, right? And so really recognizing the impact outweighing intention here. And this is important to be looking out for to interrupt, right, between other clients in the treatment environment and looking out from other staff members too, right? So intervening, interrupting when you hear those things, you know, calling that person is a transgender, right? Like, a transgender what? Transgender is an adjective, right? Or, oh, you're the first trans client I've ever heard, or I've ever had. Like, people don't want to hear that. The ways that we single people out and remind them that they're different than everybody else, that they don't belong in some way, tokenizing people, these kinds of microaggressions really add up, and folks are going to flag you and your practice as not trans-affirming. They're not going to come back for more services, right? We know that these rates of violence, drastically, the epidemic of violence, especially against Black trans women, right? When you are in a behavioral health position to help someone, right, you need to do everything you can in that first interaction to make sure that she's going to return for more services, right? That's the only way that we fight back against some of these statistics, is creating environments that are safe, that are welcoming, that are affirming, that meet people where they're at, and they're going to encourage folks to return for more treatment, right? To return for more resources so that we can help folks make decisions that move themselves towards better health and wellness. It's not happening in environments where microaggressions are just adding up. Interrupting transphobia with other clients. It's okay if someone has some concerns or has some fears, right? Human beings are naturally afraid of things that we don't know, we don't understand. And not everybody has had a lot of trans folks or gender nonconforming folks in their life, right? So if you have a client who's saying, hey, I've never been in a group before with a trans man, I don't really know how I feel about this, or what if I do something wrong? We can listen to that from a client, we can acknowledge that, right? We can allow that space for confusion and uncertainty, maybe even a little bit of fear, but we draw the line when it crosses over into bigotry, right? A thing that I hear people say all the time is like, well, what do I do if one of my clients says something transphobic? I don't know how to handle that. I was like, well, you don't let your clients say racist stuff in the treatment environment, do you? You don't let them say, make fun of people who have a disability, right? Like, we're also not going to tolerate transphobia, right? We're not going to tolerate homophobia. We want to remind everyone who's in the treatment environment that, like, everyone who's here deserves respect and support, even if you don't understand them and even if you don't agree with them. It's not our job as providers or therapists to, like, change someone else's mind about the trans community or LGBTQ people. We're not going to make every client an ally, but we can say there are things that I will tolerate you talking about in this room, and there are things that you cannot say in this treatment environment. You got to save that for when you're, talking to your buddies out on the street and not in this house, right? Not in the program. Because treatment's got to be a safe zone for everybody, right? If it's a safe zone for you and you feel comfortable and safe talking to me and everybody else here, it's got to be a safe treatment zone for this person and that person and that person too. If we're not tolerating racism, classism, ableism, then we're not going to tolerate transphobia either. What you actually say to intervene or interrupt in the moment is going to depend on who else is around, what your relationship with that person is like, and who that person is, and kind of like what you know about them and their relationship with the program, right? So if you're in a group setting and there's a trans person in your group and somebody says something really transphobic, you got to pay attention to the group dynamics. You'll know if it's appropriate to call it out right there on the spot, or if that's going to create more of a scene and more of a mess and cause more harm, right? And then you pull that person aside later. The first thing I would do, though, at your very first convenience, is pull aside the trans person who witnessed it or experienced it and say, hey, just so you know, I saw that, I'm on it, it's going to be addressed, right? We don't talk about other people's consequences or what happens like in the therapy room behind closed doors, but you can acknowledge, hey, that wasn't cool and it's going to be addressed. You're allowed to say that, right? And then with the person who made the comment, you pull them aside, you talk to them about it privately, or maybe it's a learning experience and that person can take some constructive feedback and you pull them up in the group setting, right? But find the way that's going to work for your particular group to make sure that it's addressed and that the message is clear that that kind of behavior won't be tolerated. Unfortunately, sometimes we also have to do the same stuff with other staff folks. So this is going to be handled differently based on the presence or absence of clients in the room, right? Because there is the importance of maintaining the allied front of the staff when participants or members are experiencing a lot of tension in the staff, like problems creep up. A lot of staff splitting happens, right, at that time. So pulling that person aside and having a conversation with them. I like to take the curious approach. Tell me why I didn't understand that joke you made earlier, right? Explain it to me. Once somebody starts explaining why a joke is transphobic, they usually figure out pretty quickly that it wasn't okay to say, right? Or, what makes you think, this thing that you said earlier that was super crappy and transphobic, right? Approaching it with curiosity, if nothing else, will signal to that person, I am not the one to entertain these conversations with you in the future. So just like we do with clients, we can listen to concerns and fears, but I think as another provider, right, then it's our job to respond with some education, with some facts and information, right? Other things that are like a little bit different, like we can remind other helping providers, thank you, that we don't get to pick and choose who we help, right? We didn't go get a social work license because we only want to help people from this specific group, right? If we work in this treatment environment and these are the people who are coming to us for help, then we need to be prepared and willing to help all of them. And then don't forget to remind your peers about correct pronoun usage as needed, right? If somebody keeps flubbing somebody's pronouns, pull them aside, help them practice, have a conversation with the other provider about the person whose pronouns they can't get right, right? There's all kinds of like tools and games online that you can use to practice. I like to, the pronoun thing is it's a muscle, right? Like you can't just walk into the gym and pick up like 300 pounds, you gotta work up to it, right? You are not gonna use gender neutral or new pronouns for the first time and get it right 100% of the time forever, right? Like it takes practice. You actually have to say it out loud. If you're just doing it in your head, it doesn't always translate to coming out of your mouth correctly, right? Wash the dishes. I saw Joe today. They looked really nice in that new shirt they were wearing. I wonder what they're doing this weekend, right? I hope they're not going to the movies by themselves, right? Like just say it out loud. I heard a little bit of this in the previous presentation, so I won't spend too long, but I'll say, I think it's ridiculous that when we bring somebody into a treatment environment, we have to complete this like 32-page long biopsychosocial assessment. When it's like, I just met you yesterday, tell me every like intimate detail of your life. But I think there's some things that we absolutely have to know, right? And there are sensitive ways that we can ask those questions. So, what is your gender identity, and what was your sex assigned at birth, right? If we need to know if somebody is trans or cisgender, like that's the way we get at that information. If somebody asks me what my gender is, I'm gonna tell them male. That's not gonna tell them I'm a trans person. If they need to know that for some reason, they're not gonna get the information they need. So you need both of those questions. With pronouns, hey, my name's Andrew, my pronouns are he and him. What's your name? What do you like to be called, right? Or what pronouns do you use? I shy away from the term preferred pronouns because that implies that you have a choice in what you call someone. I prefer to be called Andrew, but I guess, you can call me whatever else instead. I prefer to be called he, him, his, but you can call me she, her. No, like just these are my pronouns. This is what I use. I really liked the way that you described like, is it the other name that starts with a V? So sometimes I'll just ask folks like, hey, what's your name? Is that different from your legal name? Or do you have a preferred name that's different from your legal name? If there's a question around the name someone is using when you first meet them versus what you see in documentation. And then often we'll have to ask folks questions about their sexual history. I often like to preface this rather than just jumping into, so how many sexual partners have you had in the last 6 months, right? And somebody's like, I just met you, Andrew. Why are you asking me this? Hey, I'm gonna ask you some questions about your sexual history. Is that okay? And if they say no, that's fine. We can maybe come back to it in 2 months once you've actually gotten to know me and you trust me a little bit, or maybe I don't need to know that information. When we're talking about the types of people that, right, we're asking about someone's sexual orientation or sexual behavior. So tell me about the types of people you've dated in the past. What kinds of people do you usually have relationships? Does this ever change, right? But please only ask questions that are actually relevant to the work that you are doing together. I have actually had providers, both medical providers and behavioral health providers, say to me, can I ask you a question? I'm just curious. No, don't do that. Please don't do that. A lot of your clients or participants or members are gonna humor you and they're gonna answer that question because there's an inherent power dynamic, right? And they're gonna feel bad saying no, but they're gonna remember that you did that and they're not gonna come back and they're gonna tell all their friends to avoid you. Google exists for a reason, right? Please use it. A couple notes on physical environments. Conduct a little environmental assessment. Walk around the office. Is all of the art hanging in your office depicting cisgender people? Maybe switch it up a little bit. Get some new art for the walls, right? And when you're running a group, are all the examples you're giving in the group talking about cisgender people? Maybe switch that up a little bit, right? Gender-neutral bathroom, obviously giving people options. I was very pleased to see that there was a gender-neutral bathroom at the Austin airport. I was impressed. Nice job, Texas. Removing unnecessary sex-segregated spaces. Do you have a men's kitchen and a women's kitchen? Like, why? Can it just be two kitchens and then people can just use whichever kitchen is closest to their room? Like, things don't always need to be segregated by sex, right? Is it just like a lounge? Then like let it just be a lounge, right? If you have, policies about people not fraternizing with people of the opposite gender, like figure out other ways around that by just labeling everything like boys and girls. That's not doing anybody any good. Make sure your forms and your curriculums and your materials are inclusive. When I got hired to work at the Morris Home and they handed me my new hire paperwork, I had to choose male or female, no other option, right? No question about gender identity, no way to identify myself as a trans person, right? And I'm being hired to work in a program exclusively serving trans people. So make sure your paperwork for both your participants, your clients, your members, and your staff, right, is inclusive and represents everybody. And maximize privacy, please. Don't ask people all of these questions about their preferred name and their pronouns like in a room, at the front desk where everybody's around and can hear you, right? Pull people aside, close a door, give them some privacy. I'm almost done. Staff representation is huge, right? We all know what it's like to walk into a room and look around and be like, nobody in here is like me, right? I'm pretty adaptable, but even that makes me feel a little uncomfortable, right? Like I'm definitely the only trans person in this room, or I'm the only queer person in this room, right? So having staff who represent the population you're serving is going to lead you to better outcomes, I promise. This is shared with permission from someone who was in the Pathways program, and on their team was another trans staff member, right? A trans person, there was a trans staff person on that team, and the staff member was leaving, right? And this was a note that they wrote that I was permitted to share about what the impact of them leaving was like for the participant, right? She said, every single Housing First program needs an LGBTQ person on staff. Furthermore, a black or brown trans person on staff would be best. Words will never describe what you being on staff at Pathways to Housing means to me. It means that I don't feel alone. It means that when I want to talk about all things trans-related, I can do that with you. It means that when I feel unheard in another department, I'm heard with you. You leaving is hard. I cannot even name one service coordinator on the team besides you that I would actually be comfortable with having extensive home visits with. It's more than logistics for me, and it always will be. My mental stability, my safety, and my well-being are logistics for me. Thank you so much for the many times you have sat in my home with me as I've shed many tears with you about life. Thank you for holding space for me always about any choice or decision that I have or wish to make about my life, right? So this is a trans person speaking to another trans person as their provider, right? And I think you can feel the impact here of what that relationship meant to this person, right? LGBTQ folks, especially trans folks, are not always seeing their identities reflected among their providers. So doing what you can to mentor younger trans folks that are coming into the work, open the door for somebody who maybe doesn't check every single box of prerequisites for a job, right? And giving folks a chance, because this kind of stuff pays off in dividends with folks' behavioral health outcomes, with staff retention, etc. Last two things, allyship and advocacy. If you're not an ally to trans people outside of the work environment, you're probably not a good ally in the work environment. And if your participants, your members don't believe that you're an ally, they're not going to be successful in treatment with you. It is absolutely vital that they feel that in your presence, that you're someone who's looking out and going to take care of them, right? That means educating your funders, your partners, and other stakeholders about the specific needs of the trans community. One of the things that I was tasked with doing at Morris Home was doing all of the utilization reviews with our MCO, right? So I'd have to call up the insurance company and say, this person needs 3 more months in treatment. And the insurance company would say, but they've already been there for 6 months, and that's 2 more months than we usually give. And I'd have to explain, here are all the barriers and hurdles that this person is experiencing that a cisgender person would not be experiencing. For every 1 phone call I make for a cisgender client, I make 10 to 20 phone calls to find a comparable resource for a trans person, right? So making sure that all of the other kind of players involved in someone's care understand what's going on so that you can continue to provide the best level of service. Allowing for budget flexibility at Morris Home. We're not getting paid by the insurance company, but we fundraise to be able to provide things like binders, right? Or packers, or gaffs, or makeup, or hair. Gender-affirming supplies that help people to feel comfortable going out into the community to go see the doctor, or go visit their family, or go to a job interview. If you don't have the budget for those things, then people are gonna hole up in their room and they're not gonna go out and enroll in a GED program, right? So finding ways to fund those things, even if your insurance reimbursement isn't gonna cover it. When you're providing referrals, making sure that you're actually personally vetting those places. I've been in a lot of safe places that didn't feel very safe, right? Like a sign on the wall saying LGBTQ folks are welcome here does not necessarily mean that they're trans, competent, or affirming. So making sure you know where you're sending people. You send somebody to the wrong place and that place doesn't treat them well, that's gonna reflect on you and your work, and so make sure you're doing that. Again, practice within your scope. Don't try to be somebody's gender therapist if that's not what you're there for, right? Admit when you don't know things. It's okay not to know things. I don't know everything. If somebody asks me a question I don't know, I tell them I don't know. I'm going to find out some more information, right? You are not expected to be the end-all be-all expert on trans stuff, so don't try to be that person. And if you make a mistake, just own it. Apologize, right? Move on. And solicit and incorporate feedback from your trans clients. Are we doing a good job? What could we be doing better or differently? What needs are we not meeting for you? All right, my last couple of thoughts. Just to recap, we know that transgender nonconforming folks are going to face significant behavioral health challenges and barriers. Our job is to be providing not special treatment, right, but equitable treatment that actually meets people's needs based on what's happening in the real world, right? Providing culturally responsive care is more than just like getting somebody's pronouns right. Make sure your physical environment is up to snuff. Update your forms and assessments. Be sensitive and affirming and competent in the way that you're asking questions and the language that you're using, right? No one's going to expect you to get it right all the time. You don't have to be the end-all be-all expert, but your allyship is absolutely vital to client success. That's all I got. Intention without action is useless. Please take this information, share it with other people. Find something you can do differently in your work. Little things really, really add up. Thanks for listening to me talk.
Thank you so much, Andrew. I think I can speak for us all too, just appreciating how much information is in each of these presentations today, and how comprehensive, hopefully, the information is overall. We're gonna take a 10-minute break instead of a 15-minute break, so hopefully we won't get started too late and y'all will be able to get to dinner on time as well. So we'll come back at, what time is it now? We'll come back at 3:30 for our last session on policy and advocacy. See y'all then.
And I didn't leave time for questions, but I'm here, so if you want to talk, just come over.
All right, y'all. I am also from Texas, so I saw some friends out there. I'm from College Station for our Texas friends. Now live in Tennessee and have for almost a decade, but definitely a Southern girl at heart. We're going to start our next session on policy and advocacy, and I am really excited that we're joined today by Paula M Neira, and I'll let her introduce herself more extensively in a few slides. But if we could just give a welcome round of applause for Paula, and we'll start the session.
Hi, folks. Can everybody hear me in the back? Cool. So there's me. I'm Paula M Neira. My daytime gig is right here in Baltimore. I'm the program director of LGBTQ plus equity and education for Johns Hopkins Medicine. I always say that my three-word bio is Navy, nurse, lawyer. I'm a Naval Academy graduate. I was a line officer in the Navy. That means I was in one of our combat arms. I was a surface warfare officer. We're the folks that drive the ships. My naval career had to get sacrificed when I got home from Desert Storm, when I accepted that my gender identity didn't align with the sex I was assigned at birth. And in 1991, gay and trans folks, using those as umbrella terms, were obviously not welcome in the military. We actively tried to kick people out. Then went to nursing school. I'm an ER nurse by healthcare discipline. I am not the ER nurse that is going to fluff your pillow. I don't give a rat's patoot if your pillow is fluffed, because you have to be alive to complain to me about your unfluffed pillow. My focus was on trauma resuscitation and adult emergency care. And after doing that for a couple years, I went to law school. And then helped lead the efforts to repeal the Don't Ask, Don't Tell policy and change the regulations that barred transgender folks from serving in the military. So they thought they got rid of me, and they were wrong. But that is the background for having the conversation that we're going to have. And I really don't want to be the sage on the stage. I want this to be conversational. I want this to be interactive, because we're going to have to talk about some really contentious things. Now, the Navy pictures, that's me breaking the sparkling wine, champagne, on the bow of the USNS Harvey Milk, which is going to be one of our new oilers. That's a replenishment ship. But it's the first time in the history of the Navy has named a ship after an openly gay man. And while many people know that Harvey Milk is iconic gay civil rights leader, LGBTQ civil rights leader, what many people don't know is that Harvey Milk was an officer in the Navy who in the 1950s got an other than honorable discharge because he was gay. His naval career ended because of the animus and prejudice that existed in his time. So hopefully that ship's going to join the fleet later this year. And it shows the progress. And because we're going to talk about some pretty bleak things. Now, I'm a lawyer. I got to be the Debbie Downer at the end of the day. But also hopefully going to leave you with some things to think about that are inspiring. As you know, my understanding is folks have had a really great day listening, getting information from other speakers. And I look at that as that's the inside your practice, inside your organization. And what I'm going to talk about is the environment outside that door in which you're trying to provide care. So I'm a lawyer. Think about this as my 2 o'clock in the morning voice, the speed reading of the fine print. I don't own the copyrights to any of the pictures. Fair use, fair use, fair use. And if you don't like what I say, do not blame Johns Hopkins Medicine. Do not blame the United States Navy. You can say, Paula was a schmuck, and blame me. Because depending on who you are, how you identify, what you're bringing to this interaction, you may not like what I say. I'm going to give you 2 other personal disclaimers or caveats. I'm a Christian. I was raised as a Roman Catholic. I actually graduated from what's considered to be the #1 Roman Catholic high school in the United States, a place called Regis High School on the Upper East Side of New York. It's run by the Jesuits, so I was taught theology by the Jesuits. And I voted for Ronald Reagan. In fact, Ronald Reagan handed me my diploma when I graduated from Annapolis in 1985. So I've been a Republican, and I've been a Democrat, and I've been an independent. But in talking about policy and about the social and cultural environment today in which we're trying to provide gender-affirming care, got to talk about religiosity, got to talk about politics. So, happy so far? All right. So what are we going to do? Try to give a brief look back. How did we get where we are today? Now, this isn't a history lecture, so I'm going to touch on some highlights. But then let's talk about where we're at today. What's actually going on today? And then, more importantly probably, is what can we do individually? Now, Andrew touched on advocacy and allyship. I'm going to expand a little bit on that. Is what can we do to try to change what's going on today, make it better moving forward? And also some things For some of you, you may be new to this fight. Some of you may have been involved in this advocacy work for a long time. So some of these things may be reminders. But it's what you need to do to help take care of yourself, because this is not a fight that's going to be won tomorrow or next week or in the next election cycle. Depending on where you're at in your career, this may go on your entire career. I don't mean to say that is depressing. It's more of, gee, water's wet. But how do you stay in that fight for that long? We'll talk about stuff. All right, so the historical roots. And I intentionally put up we the people, because folks want to talk about what's the gay agenda? What's that LGBTQ plus agenda? Well, I always tell people that the first 3 words of that agenda are we the people. Because you're talking about what are the issues of treating everybody with equity, making sure that everybody can access medically necessary health care. So when we talk about society and medicine, well, first off, transgender people have always been around. The vocabulary hasn't always been there. The words we use today aren't even the same words we used 20 years ago. I look at some of my writings from 20 years ago, and I notice that I wrote transgendered. I know not to do that anymore. And certainly, you know, when Caesar was there in Rome, there is no Latin word for transgender. It's not transgender, transgenderi, transgenderorum. That didn't exist. So these are modern concepts, but the people that today we would use those descriptors for were around. The notion of a binary gender is a Western European cultural thing. Indigenous people around the globe have viewed gender as a spectrum, whether it's two-spirit, hijara, transvestite, and a whole bunch of other terms. But it was the interaction with the Western European colonists and the colonialization that changes that outlook. But society has progressed. You know, doing drag shows is not new. I was in the Navy. Show you pictures of my, crossing the line ceremony. Show you pictures of drag shows from the Civil War and World War II, and oh yeah, Shakespeare. So this isn't new. But historically, transgender folks, until very recently, and when I say very recently, I'm talking 5 to 10 years, have been portrayed in the media as pathetic, poorly, negatively, mentally ill. And it was also that way written up in our healthcare professional textbooks. My med-surg textbook from nursing in the mid-1990s had 3 paragraphs about transgender people. All 3 paragraphs are scientifically wrong, and it lumps people in with pedophiles, perpetuating this whole grooming meme. And that's what we were teaching people in healthcare professions. Again, being the punchline of the joke. That shows up in The Jeffersons, for those of you who might know a 70s or 80s sitcom, or Married with Children in the 1990s. So it is only recently that you see sympathetic and positive images. And that all plays into the unconscious bias that people grow up with here in the United States. And I'm going to make my comments very US focused. But in the 21st century, there's been lots of change. You now see transgender issues talked about in the mainstream media, on the front page of the Washington Post. Unfortunately, it's almost every day I'm reading something on the front section of the Washington Post. That didn't happen. The change in communication, the access to information changed all that. And medicine's progressed. Magnus Hirschfeld, it's a name from history. Early 20th century, healthcare professional working with transgender folks. His papers were burned by the Nazis. So we've lost a lot of his original material. In 1979, that's the first standard of care. What used to be called the Harry Benjamin standard of care, because Harry Benjamin was another physician working with transgender folks. It's now the World Professional Association for Transgender Health standard of care. And for disclosure, I'm one of the people that's contributed to the latest standard of care that was published last fall. For Johns Hopkins Medicine, where do you think the first gender-affirming surgery in the United States was done? Yeah, it's a loaded question. Hey, here in Baltimore, Johns Hopkins, in the mid-1960s. Johns Hopkins had a gender clinic. Now, this predates the standard of care. The way that they were approaching things, when we look at it through a modern lens, is dark ages of medicine. But they were one of the first programs to actually try to help folks. Now, that clinic closed in 1979 amidst a lot of controversy. You may hear a name, Paul McHugh. He's the emeritus chair of our Department of Psychiatry. His opinions about transgender folks are not grounded in science. He writes in social and religious conservative journals where he espouses his opinions. They are not the opinions of Johns Hopkins Medicine. That's one reason why I give you that disclaimer. I'm not standing here waving a Johns Hopkins flag at you. But you'll notice his name come up in the ongoing arguments that try to justify barring transgender health care. And there's been a continual movement, originally looking at being transgender as a psychopathology, the same way that looked at being gay as a psychopathology. That ended in the 1970s. Gender identity disorder, an older term, was removed from the DSM in 2013. Gender dysphoria still exists in the DSM because if you want to get paid for something in American healthcare, you need a diagnosis. And that's where that diagnosis lives. As of January 1st of last year, it's now in the ICD-11. It's now called gender incongruence. And it isn't even in mental health, it's in sexual health. When do you think the ICD-10 was enacted? When it got established. That's the current one we use now. 1990. You know when the United States accepted it? 2015. Because the AMA objected to things in it. So if it takes 25 years for it to adopt ICD-11, you're going to be interacting with insurance companies and you're going to be working in electronic medical records that are still using ICD-10 language, which I will tell you is offensive. It's out-of-date terminology that we do not use anymore. But slow progress. The whole notion of gatekeeping. Again, coming out of that psychopathological background, that notion of I got to prove to somebody that I'm trans enough to get medically necessary care. No, not anymore. But all of medicine is gatekeeping. But it's trying to help people be able to access care as opposed to being a roadblock to that care. Okay, so now we get into the touchy stuff. Let's talk about politics. All right, so the Stonewall riots happened in 1969. For many people, that is in their head as, well, that's the beginning of the gay rights movement, the LGBTQ plus rights movement. Well, there were protests before 1969. And my family actually lived down the block from the Stonewall Inn on Christopher Street in New York City. So this literally happened in my grandparents' front yard. But that's what started that increased visibility. And we're going to celebrate Pride next month. Happy Pride. Well, the first Pride was a protest and a remembrance of this riot, reacting to the harassment from the police towards LGBTQ people. Now, during the Reagan years, you have the rise of the moral majority. This alignment between religious conservatives and the Republican Party predates Ronald Reagan. This goes back to the 1960s, and remarkably, somebody like Barry Goldwater, a staunch conservative, warned of what would happen in that marriage in order to get partisan power. So you have the rise of the moral majority. That's Jerry Falwell with Ronald Reagan there. And then you have the AIDS crisis. The government completely ignoring a health crisis because it was perceived as a gay disease. And it was only when straight folks, because of blood transfusions, started to get AIDS that anybody really started to care at that national level. So then you go to the 1990s. Anyone old enough to remember Pat Buchanan's speech at the 1992 Republican National Convention, which was basically a hate speech, igniting the culture war, reinforcing using queer folks as a political scapegoat for partisan advancement. Now, this Project Blitz, this was a concerted idea between religious conservative groups to influence legislators to enact basically a theocratic, Christian nationalist, Christian fundamentalist worldview through the power of the government. They've morphed a little bit because they got some visibility that they didn't like. But I'll talk a little bit in a second about that current alignment between groups that are all part of this. And it sounds like, well, I should be wearing a tinfoil hat that I'm talking about conspiracy theories. Well, it's not a conspiracy theory if you can actually look at their own words and tell you what they're doing and take them at face value. Now, it's important as practitioners to understand that this is the environment, this is what's shaping your ability to provide the care. This is what's shaping what's impacting the person coming in asking for help. Now, one of the things that's changed to narrow this focus very much so much on transgender folks is because of progress. The Supreme Court issued a series of decisions validating the place of gay folks in society, striking down anti-sodomy laws, recognizing that, marriage equality is the same for everybody. In Bostock in 2020, that's when the Supreme Court for the very first time said that you cannot discriminate on the basis of gender identity or sexual orientation because those are forms of sex discrimination. That's a Title VII case. Title IX is what governs the provision of health care. Title VII would govern your interactions as an employee or an employer. So that's what's behind this pivot to attacking transgenders, because the social conservatives, these folks that are trying to impose a worldview that's grounded in religiosity, saw that, hey, wait a second, we're losing the fight against gay folks, but hey, if we shift our focus to these transgender folks, and we approach it kind of in the same way we approached abortion, we can win. So that's part of this bigger framework that's shaping the law and policy. So I told you, history. The law hasn't been really favorable to queer people. Anti-sodomy laws, like I said, existed up until Lawrence. You will find states that still have these laws on the books, and they are hoping that the Supreme Court overturns Lawrence, because then they can put these laws back into enforcement. Anti-cross-dressing laws, again, trying to enforce this European culture notion of gender, this very rigid binary and what that's supposed to mean. Here in the States, that goes back as far as 1848, and Tennessee passing an anti-drag bill. Florida just did the same, by the way. It is an attempt to go back at this. The first legal challenge to excluding transgender people from the military wasn't in the 2010s, after Don't Ask, Don't Tell repeal. It was in 1981. And the courts, in a series of cases over time, kept upholding this ban because they were relying on medical experts who knew nothing about transgender health care. As I said, employment discrimination was legal up until the Bostock case in 2020. You may hear about the Equality Act. The ENDA, the Employment Non-Discrimination Act, was the earlier attempts. We've been trying for 50 years to get this passed through the U.S. Federal process, and have never done it. That act would modify Title VII and Title IX, which are the civil rights laws, to make it explicit that you cannot discriminate on the basis of sexual orientation and gender identity. And again, for partisan political reasons, it never passes. Now, you may hear about the Affordable Care Act in Section 1557, which is the non-discrimination part. That section has never been enforceable by the federal government because every time it's been enjoined. In 2016, the day before it was supposed to go into effect, a federal judge in Texas enjoined it across the country in a case that was brought by the Franciscan Alliance, which is a health system run by nuns, the Christian Medical and Dental Association, and the attorney generals of several states that are controlled by the Republican Party. A guy named Reed O'Connor is the judge in question. He is the same judge that has tried to strike down the Affordable Care Act. How many of you have ever heard the term forum shopping? Okay. What that means, and any good lawyer knows how to do it, when you file a case, you try to file it in the jurisdiction that's going to be most favorable to your side. Well, the judge in this federal district is a Christian nationalist, homophobe, transphobe. So all of these cases that go after LGBTQ rights, and particularly healthcare lately, are being filed in Texas because they have a sympathetic judge. Now, I know all of this sounds, oh my God, this is really bad. Well, now let's talk about the current status of things. So this year alone, there's been over 650 anti-LGBTQ bills across 46 states. We're in Maryland. You say, oh, hey, blue state, cool. Well, the Republicans in Maryland tried to introduce a bill that would have barred transgender kids from playing sports here in Maryland. That did not pass in committee. We did pass an expansion of transgender health care under our Medicaid program here in Maryland. During that debate, the Republican legislators tried to put in an amendment that would have barred gender-affirming medically necessary care to youth. That amendment wasn't accepted and was voted down. But even in Maryland, and again, in a partisan fashion, the goal is to remove queer people from public society. And many of these bills are targeting transgender youth. So I said, it's the idea to erase folks, ban gender-affirming care, embed this discrimination in the law under the guise of religious liberty. And it's to build structural barriers to change. And this is intersectional. Voter suppression. Because it's seen as a way to maintain partisan power. Let me stop there. Any questions or anything? Everybody tracking, anything? What the heck's that coming from? Cool? All right, so this is the different facets of this agenda. Criminalize or penalize provision of gender-affirming care. Let me go after your license, because if I threaten your license, you're not going to provide this care. How many of you want to be a plaintiff in a lawsuit challenging the constitutionality of this stuff? Define gender-affirming care as child abuse. Back to Texas. Investigating parents that are supportive of their trans kids. Prohibiting the ability to update your driver's license or your birth certificate with your gender marker so that it matches who you are. Because if you have ID that doesn't match, you open yourself up for harassment. Don't even talk about queer folks in school. The Don't Say Gay bill in Florida, which started out, okay, well, we don't want those really young kids. Well, now it's, we don't want any kid before the 12th grade talking about this stuff. Ban the books that talk about queer people. Prohibit people from using pronouns. Yes, one of the states wanted to impose a $1,500 fine on transgender people for using a pronoun other than the one associated with the sex they were assigned at birth. Now, they would say biological sex assigned at birth, or biological sex at birth. Require teachers to out kids. Don't play sports. And there's all kinds of both mental and physical health ramifications of that. Reimpose a ban on transgender military service. The Republicans in the House and the Senate have introduced bills this year to make it a law. Now, politically, it's not going to go anyplace for the next 2 years. We have major elections in 2024. So this is a signal at the federal level of what you can expect if there is a change in administrations. There's also a federal bill to make a nationwide ban on allowing transgender kids, and I'm really talking about transgender girls and young women, from competing in interscholastic, intramural, and intercollegiate athletics based on their gender identity. And in Missouri, the Attorney General is trying to write his own medical standard of care for providing gender-affirming care, which every single reputable healthcare organization has condemned. Because one of the things that you need to be aware of as me and an advocate is, yes, we always have to provide factual information. We have to be grounded in the evidence and understand that those folks who want to impose these kind of bans aren't bound by those same considerations. And they do not care. Because in every single state that's enacted these laws, healthcare practitioners have tried to give this information to their legislators, and they've been ignored. So again, and you can look online of where the level of policy is. And if you notice that, it's worse in the South, worse through, the Mountain West. So again, what's behind it? Partisan politics, religiosity, and non-evidence-based policies and decisions. And I got Yoda up there. I'm a big science fiction geek. But yeah, it's fear. It's playing into people's ignorance. It's playing to their fear of the other, the fear of the unknown. Because it's much, much easier to rally a political base by giving them somebody to hate than it is to give them something else to rally around. And how many of you know that that quote from Yoda is actually the paraphrasing of a Muslim philosopher from the medieval times? Yeah. George Lucas didn't come up with that phrase. So again, we talk about unconscious bias. We all have it. It's been formed by our identity, what we bring to the table, how we view ourselves, shaped by our family, our friends, our faith group, the law, the government, social media, the media, all of that stuff. And until very recently, it's teed us up with a bias against transgender folks, with a certain type of unconscious bias called cis-heteronormativism, which is this bias and this belief that everybody is supposed to be cisgender and everybody is supposed to be straight, and that's the way it's supposed to be. And if you're not, you chose to not be straight and cisgender. And all of those discriminations, all of those restrictions, you brought it on yourself. And none of it's grounded in reality. None of it's grounded in lived experience, and certainly we as healthcare professionals that are scientists, it's not grounded in the science. It's grounded somewhere else. And this is just a slide about cis-heteronormativity, this whole notion of blue and pink, gender reveal parties. You're going to hopefully have a healthy kid, and in about maybe 8 to 10 years, you might figure it out whether you got a boy or a girl, or a kid who's non-binary. Now again, I already hammered this once. This is alignment with hate groups, and when I use the term hate group, I'm talking about organizations that have been designated by the Southern Poverty Law Center, which has set up criteria to identify a group as a hate group because of their willful, intentional, deliberate misrepresentation about LGBTQ plus people. And this notion of religious liberty is what's being used as a weapon. Florida just is in the process of enacting a law that would allow healthcare professionals to deny care to queer people. Mississippi already has one on the books. Because it's not religious liberty in the sense of you get to practice your faith, I get to practice my faith, we all get along in this secular country with a plural First Amendment with an with the Establishment Clause. Well, the current Supreme Court has gutted that clause, which means that the government can't pass a law that favors religion because of the Free Exercise Clause, which also says that the government is going to restrict somebody's religious beliefs. And this argument about religious liberty has now been morphed. So instead of it being a shield to protect people's ability to do it, it's now a sword. And I said, I don't think you can read those, and I'm not going to read them to you, but I put the slides in the slide deck. These are the actual words in the Texas GOP party platform. Homosexuality is an abnormal lifestyle choice. We oppose all efforts to validate transgender identity. They intentionally use language that is outdated and offensive. We support legislation that bans care. We affirm God's biblical design. So you have a political party invoking a deist view to justify civil policy to deny people their civil rights. We support the definition of marriage as a God-ordained legal and moral covenant between one biological man and one biological woman. Again, Paula isn't being hyper-partisan. Paula isn't sitting up here taking cheat shots. This is their own words. And you need to be aware, because again, depending on where you're going back to practice, you're going to encounter these kind of arguments. I said, it's never been about bathroom safety. It's been as much about the bathroom as it was about the water fountain. And the impact that it's having on kids. 86% of transgender, non-binary youth, negative mental impact just from these debates. Most can't access mental health care. Less than 1 in 3 live in an affirming household. And 3/4 of them have been discriminated against. So, doom, gloom, bad. Okay, so now how do we fight? Well, what you can do is your language matters. I know the folks that have given you the presentations throughout the day have given you some really good insight on how to do that. Actions matter. Has anybody talked about transgender broken arm syndrome yet? You ever hear that? Have heard that phrase during the day? Okay, we'll talk about it in a sec. And then practice gender-affirming care, which is holistic, patient-centered care. So transgender broken arm syndrome. It's when we forget that transgender people are human and they have healthcare issues just like every other person. And we only see them in the lens of their gender identity or their transition status. And I always use myself as an example. I played soccer when I was younger. Paula, the roly-poly goalie. I could be playing soccer, I could break my arm during the soccer game because somebody else kicked me in the arm. I come to the ER. Hi, yeah, broken arm. Playing soccer. Yeah, medical history, I had my tonsils out. I had gender-affirming surgery in 1995. Yeah, I take my diabetes medicine, I take my blood pressure medicine. Oh yeah, I take estrogen every day. You're transgender? Oh, no, they never taught me in medical school. They never taught me in nursing school. I don't know how to take care of you transgender people. No, somebody else has got to come in here and take care of you. I call it the immediately stupid response. Why am I in the ER? I broke my arm playing soccer. Let's see. Neurovascular compromise, check. Maybe splint, get some x-rays. Oh yeah, pain medicine maybe. You know how to take care of a broken arm. So why did you forget that once you found out that I'm transgender? Or it's, oh, you're transgender? Have you had the surgery? Do you have a penis or a vagina? I have a broken arm. And the song doesn't go, the penis bone is connected to the forearm bone. Oops, sorry. Doesn't go that way. An inordinate focus on the status of the patient's genitals or transition status that is divorced from the clinical presentation. And, oh, you're taking estrogen. Well, that's the reason why you broke your arm. No. I broke my arm because some 6'10" Amazon on the other team used me as a kicking tee. Thank you. Automatically telling transgender people that the cause of whatever their clinical presentation is related to the fact that they're on hormone therapy, regardless of the clinical presentation. Now again, if I came in complaining of shortness of breath and chest pain, knowing that I take estrogen is important, and then you want to find out what kind of formulation I'm taking. Older formulations had higher instances of PEs and DVTs. That's relevant. Telling me to stop. You wouldn't tell any other woman goalie, oh yeah, you need to get that estrogen out of your body because that's why you're going to break your arm playing soccer. Yeah. And I'm intentionally trying to be a little bit glib and funny because when I'm glib and funny about it, it sounds like that's ridiculous. Well, yeah, it is ridiculous. but it happens. So again, within the organization, know what kind of organization you're in. In many states, the number of beds in the hospital that are affiliated with religious-based, particularly Catholic organizations, is problematic. Insurance, who's covering what? We've made lots and lots of progress, but now you're seeing that progress under attack. Staff training, it's great that you folks are here. How do you train the staff? Facilities, when we talk about signage, yeah, just having signage alone, there's a big transgender pride flag on the wall, but we keep misgendering our patients. No. It's got to be all aligned. Look at your forms and your policies. I will almost guarantee you that they were written from a perspective of cis heteronormative bias. Who gets a urine pregnancy test? Females of childbearing age get a urine pregnancy test. Well, that excludes transgender men that have a uterus and can bear a child, or non-binary folks assigned female that have a uterus. It's, when was your last period? Well, I always answer that question like this. When was your last period? I've never had a period. I've had a comma and a couple of semicolons in my life, but I've never had a period. Because I'm a smartass. The question really is, do you have a uterus? Because then if I say yes, then it's okay, how long has it been since your last period? That's an inclusive way of trying to get information you might need, but in a way that doesn't automatically exclude folks. And again, look at our records. Do we have this, well, I know because of meaningful use, all of the electronic medical record systems have the ability to capture SOGI information. The question is whether or not your organization has turned it on. So back to the being an ally and advocate. First off, you got to look at the person in the mirror. You got to look inside. What are you blind about? What's your learning curve? And all of us have a learning curve. I do this, this is where my health career has led me, and I got blind spots. And I learn something new almost every day when I'm at work. Listen to the community and your staff members. Learn from reputable sources. If you hear somebody mention, well, Paul McHugh says, I already told you, you can discount that. Or about the American College of Pediatricians, which intentionally chose their name because people will mistake it with the American Academy of Pediatrics, which is the actual official organization. The American College of Pediatricians is an anti-LGBTQ, so-called Christian hate group in Gainesboro, Florida, with about 700 members. And then lead. Speak out, speak up, set the example. Not going to be easy, not going to be tough, might actually place yourself at risk. But what does it mean? It means don't be a performative ally. Don't tell transgender people that they can only advocate for themselves in a way that makes the cisgender majority comfortable. I've been in meetings this year. Well, they're our colleagues. You have to give them the benefit of the doubt that they're coming from a place of ignorance. And it's like, no, I don't, not anymore. Access to that information, the medical stuff, is widespread. So now when somebody opposes providing care to transgender people, I am not giving them the benefit of the doubt that this is just, they just don't know. This is grounded in something other than the science. And have no tolerance for willful ignorance or bigotry, the intentional misrepresentation of science and the data. There is no such thing as social contagion, gender dysphoria. I don't become trans because it's trendy and my friends think it's cool. That does not exist. And when you're confronted with people that want to use pseudoscience, want to intentionally misrepresent the data, you do not let them every single time. You don't let them get away with the big lie. The Washington Post just had a front page story, front page above the fold, that said a poll of Americans, that a majority of Americans favor the attacks that the GOP is launching on the transgender community. Because they're playing to people's ignorance and fear. And they've bought into this because there aren't enough voices saying, no, this is wrong, in the bubbles that those people are talking in. Which means in your circle of influence, not everybody has a national platform. Not everybody gets invited to national conferences to get stand up here and tell you this stuff. But you have a circle of influence wherever you're at, whether it's your family, your friends, your practice, your community, your faith group. And when somebody stands up and says this nonsense, you say, wait a second, no. Here's the evidence. This is not true. And challenge it. Don't let people gaslight you. So there are some pamphlets you can get from the Trevor Project or PFLAG with good information, and those are two good resources for you. So now I've really been Debbie Downer. Really giving you a lot of heavy stuff. And that's true. That is the fight we're in. And for folks in the community, it's an existential fight. There are people that do not want people like me in our society. That's a simple statement. Now, I've been fortunate enough that I've actually been in a minefield in my life. And I've had some training about fighting and being resolute in the face of people that want to hurt you. Not everybody has that kind of armor. But we have to be resolute because this is not going away. And if it proves effective against transgender folks, who is next? What's the next marginalized group that they're going to go after? One of the toughest lessons to learn is, for those of you that are just getting into really being involved in this stuff, injustice will never come fast enough. It never will. And for some folks, it is never going to come in their lifetime. And the people I always think of are black folks in the early 1900s or the late 1800s who might have been enslaved and then saw freedom, saw the promise, and then saw it snatched away and didn't live long enough to see the civil rights actions of the 1960s. The same thing is going to happen today with different groups for different reasons. So all we can control is what we do in our time. To be in the fight, to try to advance things while we can be in the fight. Be strategic. Yelling and screaming make you feel good, but if it doesn't actually change the outcome, so figure out how to change my system. How do I advocate inside systems for change? What's important to them? And I always talk in military terms. Find out what we call their center of gravity is. Most big academic medical places, they care about funding and reputation. So that's what you go after. You show why doing this, besides being the right thing to do, here's why it's important for our organization to do this. You use their language against them. And you got to take care of yourself. You have to know when you need to step back and let somebody else carry the load. Because I said, this is a long fight. This isn't a short little battle. And I said, actual victory. And I use a don't ask, don't tell example. There were folks who chained themselves to the fence outside the White House during the battle to repeal don't ask, don't tell. I knew most of them personally. They will swear up and down that that was an important step in repealing don't ask, don't tell, and I will tell you that no, it wasn't. It didn't change one vote in the Senate. And that's where the battle was. Made them feel really good. Made the people on the political left feel really good. People who would never join the military, because remember, we got a volunteer military. And it didn't impact actual victory. But winning feels pretty darn good. And a bitter pill that I've had to learn personally is that sometimes you're going to do things that you're never going to see the benefit of. My career ended too soon. It took too long to change the rules. That's why I'm sitting here talking to you today and I'm not out at sea someplace. But that's what this is about. It's about trying to change things, making it better down the road. And you only got two choices, folks. You fight or you quit. Now, taking time to step back, to recharge, to take care of yourself is not surrendering. It's not quitting. It's being strategic. But those are your only two choices. And for those of you who are cisgender allies, you have a little bit different situation. You can take a day off. Transgender folks, gender expansive folks can't take a day off. I can sit on my front porch and I cannot think about stuff for a couple hours. But that doesn't change the fact that I'm a transgender person in the United States sitting on my front porch. And people are gunning for me. I can't get away from that. And I'm somebody with immense privilege. So if it affects me, how does it affect the most marginal, the most vulnerable? Someone that's facing discrimination in an intersectional way. Yeah, they can't get away from that fight. And lastly, the thing, that I want to end on a kind of an uplifting note is keep the faith. Now, I swore an oath that I will bear true faith to the Constitution. And what it means is, yeah, I have to believe in the long game. Eventually, we are going to have, in the terms of the Constitution, a more perfect union, where people are going to be able to access medically necessary care without fear of discrimination and prejudice. Because it says, tyranny like hell is not easily conquered, and bigotry and prejudice are the minions of tyranny. And if nothing else, we get to wake up every day knowing that we're in an important fight and we make a difference. And that's a feeling of satisfaction that no matter what the big picture is, you're making a difference. And that's a pretty darn good feeling. So thanks, and what questions have you got? Or have I just shocked in awe? You're between us and the bar. Yeah. Or was that a stretch?
No, that was
Oh.
that was a raised hand. Thank you for your talk and for all of the policy things. I have a question about what you were talking about funding and reputation and how that influences things. I'm from New Mexico, which actually has really great policy right now. It completely protected gender-affirming care and abortion care, but the funding is just absolute nothing. And so it's really, there aren't really any gender-affirming surgeons, and it's really hard to convince resources from other parts of the U.S. to build there. Is there anything within policy or within the structural change work that you've done that you think could be a good angle at looking at something like that, or a good way to support the policy with implementation tactics that can help support with that?
Well, so in looking at in particular states, the will is there, the money is not. So how do you motivate the people that have the purse strings to spend the money? And it's, on some level, it's to give them a cost-benefit argument. There is literature and research that shows providing gender-affirming care is actually cost-benefit positive, because you offset all of the cost for the health care that you're paying for gender dysphoria, anxiety, depression, suicidality. You're spending way more money on that stuff than what you would be spending for covering somebody's hormones or being able to set up a gender-affirming surgical practice. It's ensuring that the insurers don't have any exclusions in their care, ensuring that the state includes it in their Medicaid package proactively. Some states are silent. Clearly says that this is medically necessary care, we're going to cover it. And it's that slow progress. But again, it's showing that, okay, this is actually to our bottom line. And if we're a organization that is clearly supporting this, we can then also make the argument that we become an employer of choice. As from a military perspective, I can tell you that all of this nonsense in some of these southern states where we have lots of military bases is impacting people's decision about where they will accept a transfer to, or whether or not they're even going to stay in the military, or whether or not they're going to join the military. And the military leadership is aware of that. And it'd be the same thing, is that if you're in one of these states that's engaged in this practice, know that you are, you're going to see a brain drain, and people aren't going to come. Hey.
I can't help but notice that hasn't been a huge backlash by corporations against the states that are passing these affirming laws. Disney aside, who's only protecting their bottom line, nobody seems to be boycotting Florida overall. So do you think that there's value in encouraging these companies to take their business out of these states? Has that really worked before?
Yes and no. And when I say yes and no is they're like anybody else. They're businesses. They exist to make a profit. If you can make it financially bad for them, then yes, they'll modify their corporate behavior. But that takes a whole lot of resoluteness. That takes a whole lot of organization. And it takes convincing the leadership to do so. Like you talk about Disney. It's, from what I understand, what I've been able to see in the media, the senior leadership of Disney, their leaders are dead set. They're not going to let, the governor of Florida attack their free speech, because that's what this is all boiling down to. Is, for the folks that aren't aware, Disney spoke out against the Don't Say Gay bill, and the governor has been trying to attack the business benefits that Disney has by doing their business in Florida. And the threat from Disney is obviously, okay, well, we don't have to stay. We don't have to hire people in Florida. We don't have to stay here and contribute $1 billion to your economy. We can go somewhere else. Now, those are big threats. Those are big threats. But yes, engaging with companies. And when we're talking about performative allyship, right now there's a big issue with Anheuser-Busch. Because Anheuser-Busch basically threw a transgender woman that was one of their online influencers onto the bus, caving to pressure from the far right. So, yeah.
I was just thinking about the cost-benefit analysis piece, and this idea that somehow trans oppression is bad for the economy, and that depression, anxiety, suicidality don't actually create quite a bit of wealth for nonprofits and the rich and the medical industry. Part of me just doesn't want my dignity to be attached to it being economically viable, but another part of me doesn't think that my impression is bad for the economy. I think that it actually does stimulate quite a bit of wealth. So I don't know, the idea that by pushing a narrative that it's bad for us feels really assimilationist to me, I guess.
Okay, do you want to win?
I think we might have different definitions of what that looks like, but yes.
Okay, accepting you in society for who you are. I'll define victory in those terms. But that's not going to happen unless you go be really strategic about it. And that means sometimes the strategies don't feel good. And where the limit is for every individual is, where's my integrity and where's my honor? Because those are two things that are absolutes. I cannot support a policy that compromises my integrity or my honor. And anything short of that is then you start looking at it through the lens of being strategic. It didn't feel good when Don't Ask, Don't Tell was repealed and it didn't address transgender folks. But it never would have happened if you had conflated the two issues. And that would have forestalled eventually getting transgender open service. And it doesn't feel good. I'm not going to stand here and tell you it is. But again, it's how you want to define victory, because you can say, no, this is where I stand and I'm not going to compromise, and you are never going to change the system doing that.
I hear you, and I think that strategy is viable because I do think nonprofits, the medical industry, prison industrial complex, all generate quite a bit of wealth off of aggression. So like saying that like dysphoria makes more wealth than anxiety, like that doesn't make sense to me.
Yeah, and I mean, I'll defer to the folks on the economics, but yes, does that happen? Absolutely. But you do have to make the risk-reward arguments.
It kind of reminds me of like battle of like in order to receive like a trans-affirming surgery, right? You have to be diagnosed with a mental disorder, gender dysphoria, right? In order to access that care. And I think what I've heard other people say that I find to be like a really useful phrase for these kinds of debates is that this is what we all really on the road to change, right? Like where like we don't want to not in the abolitionists, right, but still want to provide good care to trans people who are incarcerated, right? It's like we don't want to pretend that system doesn't. I don't know.
Yeah, yeah.
It's a useful phrase for me when I think about these kinds of things.
It is. I mean, there is no. I mean, there is no easy answer, and this is, requires having to look at it through all the lenses. That moral, personal lens. Again, I got to the point in my life where I could no longer deny who I was just simply to continue to wear my uniform, and I knew what the consequence of me doing what I was doing was. And we all have to do that individually. But it's like trying to change these systems. Yes, many organizations absolutely benefit from the way the system was structured. The system was structured with racism in mind. The system was structured with cis heteronormativity in mind. And wanting to change that system gets back to that, sometimes it's never going to happen fast enough. And barring revolution, it's not going to happen outside the system unless there's a major thing to happen. The forces of oppression are not going to wake up tomorrow and say, gee, we were really bad and we need to change. That ain't happening. So if you're going to try to change the system from the outside, you better have a whole lot of money and a whole lot of power, because that's the only way it's going to happen. And that's a bitter pill. I'm not standing here trying to sugarcoat it. That's bitter to understand. But unfortunately, that's the way the world is, not the way it should be. I always talk about, I talk about reducing the delta, reducing the difference between the rhetoric of our words, which are really lofty things, and the reality of people's existence, which often don't match. And that's a long, slow slog. Wish it was faster. But you stay in the fight, you take your victories where you can, and you keep trying to make it better. And like I said, the guardrail is you don't compromise your honor. Yeah. Yes. Yeah. And I'll hang around if folks have other questions or want to chat. I know we've got another.
But do we have any data on people migrating out of these states as these laws? I mean, we're talking about trans youth, and then we also talk about being in large urban areas.
Mm-hmm.
Where we're seeing a lot of unhoused trans youth. And is there anywhere where we can see these patterns of movement?
I've seen anecdotes, but I haven't seen an actual study yet or a poll yet that has percentages.
I know that the Children's Hospital of Philadelphia, which runs the gender and sexuality clinic, the director of that clinic has helped start gender clinics all over the country, and is working pretty closely with me, who's the assistant secretary of health, to strategize around how to keep kids in care in states where gender-affirming care providers is being banned. Most families don't have the financial means to just get up and move
Because right now, like, one of the things about collecting data is like the Healthy People 2030. There are no actionable objectives right now that address transgender issues. The three are still developmental, which means they don't even have baseline data for them.
I have to say that well, is the more I experience my exposure to different clients, and that's what I would say in my own experience at different clinics, and more when I'm driven to serve those in most need. And that's what I would say, like, you know, seeking that, that's what I'm more exposed to even topics like this, and clients experiencing that their identity in their, how reaffirming they feel with their gender. That's when I see that even I question myself, like even when I was previously more serving the Latinos, now I'm serving more diverse, but it's more like a diverse African American white. That's what I'm really encountering more, really questioning how, even before, like my own opinions and my own perceptions, and even in conversations, how would say things about it. So like these presentations that I go through the whole day is really challenging myself. That's why even when I go not only to my workplace, but it's even at home, I'm going to interact with my wife and my children on that. And when I listen a comment or even there's something that is going to be different really when I go back after the whole conference. But this is like how even at home I can really look forward this type of change. That's what I see, how working on me, that could be really impact even the whole movement, if you want to call it. That is the way it is. It's really how living my own perceptions and my own even the questions about my own identity, how I am the person who I am. But that's how I see, like listening to your stories and your testimonies and even with some of my recent experiences with my clients, really it's transforming the way I've been even practicing medicine. Because that's why I see like how affirming my practice as a family physician is in that this type of exploration, being the provider that I wanted to be, being in tune with my clients' needs, but also in tune with really who I am, to be the authentic person that I really want to be, but really in tune with society. So really, well, thank you so much.
Well, thank you for sharing that. You know, it reminds me of a quote from Maya Angelou that talks about, you do the best you can until you know better. And then when you know better, you do better. And it's a continual growth process. It's a continual being able to look inside and being open to the notion of change and not afraid of something new, something different. So thank you for sharing.
Unfortunately, I'm just going to briefly remind you about something not as inspiring, which is if you're done with your evaluations, if you would put them at the end of your tables and then I can pick them up afterwards, that would be great. To close this out briefly, I thought we could hear from someone who's been working really hard on integrating clinical service and advocacy into our everyday work, and it knows a lot about transitioning us into how gender-affirming care fits into the healthcare for the homeless community and field. So I'm going to pass it now to our Senior Director of Policy, Barbara DiPietro. And I promise we're almost done. Hang with us. I know we're over 4:30. But here's Barbara.
Thanks very much. I just have a few minutes, and I don't want to get in between anyone and happy hour. So that is the place I'm in. So one of the things I just wanted to take where Paula left off and just frame this for where we're leaving out today. And one of the slides that you used had a photo that said, and what is this? It's not about the bathrooms, just like it was never about the water fountains, right? And it just seems to me that we got 34 million people that go hungry in this country every year, and Congress is trying to take food assistance away. We got 15 million people who are about to be cut off Medicaid, 2 million more through the work requirements that Congress wants to put in place, and yet still, they want to take health care away from people. 22 million households pay too much for housing, and yet Congress is taking money away from housing. 2 million people incarcerated, more than any other country in the world, to include China, which has 5 times as many people. We got 14 states that have restricted reproductive care, more continuing to try. We got 18 states that have banned critical race theory in schools, so you can't even learn about history. We got 15 states that have passed anti-sanctuary laws that are clearly threaten non-citizens. We got countless states and cities that are constantly sweeping encampments with absolutely no regard to the health and well-being of the people that live there. And we have black men who were lynched in public increasingly in this country. The most recent one, Jordan Neely, and his killer was called a hero. All of this is connected. There is a widespread and concerted effort in this country aimed at taking away the humanity from lots of different groups of folks. And so one of the things that I just wanted us to kind of be focused on here today is that if you're in this room and you're doing the work of gender-affirming care, you're part of something bigger going on in this country. If you're in this room, you're not just part of the healthcare community trying to do the right thing. You're part of a group of people that is centering the values of dignity and respect and humanity and justice for people. And we're currently, it feels like, in a battle for the soul of the country. And this battle determines who we're going to be, who we are now, who we're going to be. And so I guess there's 2 things that I just wanted to leave us with here in this room today for this conference, right? Your work, your voice, and your advocacy are really important in this broader battle. So that's number 1. Number 2, as a community linked to lots of different intersectional communities that are clearly under threat because the dignity of humanity, right, is under threat. How do we find joy in this struggle for justice together? How do we find joy in the community we create with each other as we put these values into practice? I think that's what this conference is about. I think that's what this work is about, and how we connect to other people. How do we find the joy in the struggle for justice, which is long and hard, I think we've established, but we're a part of a bigger piece going on right now. And I just want to say thank you for your work, for being here today, for being part of a community of justice that matters. Thank you.